So welcome back everybody, and I hope we had a good time and you could have a good break. Now what I'm going to do is I'm going to talk about one of the most important topic of radiology for a MBBS graduate, both clinically as well as for your practical life. And I'll try to go very basic. I will go from the smallest possible thing and I'll go to the toughest things. So again we will do the same thing. We'll gradually do the technology, we will look at the technique, we'll look at the anatomies, and we'll also look at the diseases. That will be my approach in chest X-ray. I'll look at the pulmonary diseases as well as cardiac diseases. Okay, everybody gets it? And I am also going to tell you something which is very important, that I keep reading everything you ask in the chat box. I read everything. But if sometimes if you are writing a question again and again and I ignore it, that means sometimes that doubt may not be a doubt, and if you read your own doubt again, you will get it solved. Like I see somebody has asked, sir, what is pilocytic astrocytoma? It's a variety of astrocytoma. Pilo means hair, cytic means cell. So these cells on microscopy have hair-like projections. So it's a pathology term, nothing to do with radiology. So I might not answer that question, but just to get an idea that it is something to do with pathology, it's a subvariant, subtype of astrocytomas. Okay, everybody? Okay. Now, slowly, as Dr. Donia Nobe has asked me, we will start with the first image of the day. This is how a chest X-ray is being done. Everybody now look at the screen. Everybody now look at the screen and tell me, where is the film present? Where is the film present? The film is present in front of the patient. The film is present in front of the patient. Everybody gets it? And where are the X-ray beam coming from? Where are the X-ray beams coming from? The X-ray beam is coming from behind. Clear? The X-ray beam is coming from behind. The film is kept in front. Okay, I'm repeating in both English and Hindi. X-ray beam is coming from posterior of your body to anterior. पीछे से आगे. Posterior to anterior. Let's call it chest X-ray PA view. What are you looking at? We are looking at a chest X-ray PA view. Everybody now try to answer. Now this is what is most commonly done for respiratory illnesses. So they will not ask you this, but this is so commonly done. So whenever you say chest X-ray, as a doctor, whenever you say chest X-ray, they mean chest X-ray PA view. The meaning is film is in front, rays are coming from behind. Okay, now everybody quickly tell me, what is the, anybody now tell me, what is the position of the patient? Patient is in erect position. Patient is standing up. Everybody gets it? Patient is standing up. And what is he done to his shoulders? If you notice, this patient has kept his shoulders like this. He is trying to rotate the shoulders so that the scapula is removed from the X-ray film. The shoulders are rotated. And the third is, whenever I'm sure some of you might have gotten their chest X-ray done during medical examination. They will say, take a deep breath, hold it, full inspiration. Okay, I'm repeating. Nothing of this is a MCQ. It is very basic, very basic. I'll build it up. But can you answer? Chest X-ray PA view is done in, anybody? Erect position. Shoulders are rotated in full inspiration. Now I want all of you now to see with me, very slow. This is the source of your X-rays. This machine is the source, and this is the patient. So X-ray beam is coming from the source through the patient going into the film. Okay. So the distance between the X-ray film and the source is called as film focus distance. The distance between the X-ray film, okay, and the source is called as film focus distance. And I think Shubham Manoj has already picked up the question, but let's see if you can answer. This film focus distance is 180 centimeter in a chest X-ray, which is same as 6 feet. While for rest of the body, in other X-rays, in other body parts, in other X-rays, this distance is 100 centimeter. Okay. Now Soumya, Shubham, Hameen, I will give you a question and you need to tell me the reason. I am making a assertion. I am making an assertion. I am saying chest X-ray PA view is done from a distance of 6 feet or 180 centimeter. Okay, this is my assertion, which is correct. This is true. You need to tell me the reason for it. Okay, you need to tell me the reason. Okay, this is how the MCQs will be framed. They want to ask you something very basic. I find it basic. All X-rays are done at a distance of 100 centimeter, but you might have seen in your hospital also the chest X-ray room is more longer than the other X-ray rooms. Why is chest X-ray done at a distance of 180 centimeter? Okay, and I can already see some of you are able to answer. Let us see an answer now. Okay, now see, suppose this is your thorax. Suppose this is your thoracic cavity and this is your heart in the center. Okay, and suppose this is your source of X-rays at 100 centimeter. Now suppose, listen to me all of you, suppose I am sending my X-rays from 100 centimeter, these rays will diverge because our thorax is much larger than the source. So the X-ray beam is coming from a source in a divergent manner and covering the thorax. If the rays are divergent, what happens is on the film, the central part gets magnified. On the film, the center part gets magnified. But if I do it from 180 centimeter, that means I go further away, it is like going to the infinity. Remember, if you are coming from very far off, the rays will become parallel. So from 180, from 6 feet, the rays become more parallel. So it reduces. The reason is to prevent or to reduce cardiac magnification. Okay, everybody understands? Everybody follows? Okay. Now some children are saying, sir, go fast. Some children are saying go slow, but don't worry. I will go at a pace where I teach every one of my students. Don't worry, okay? And I've been teaching for so many years. Don't panic. If I tell something fast, that means it is less important. If I'm spending time, it means it is important, okay? Everybody now try and answer, my bachas. Everybody. Chest X-ray PA view is done at a distance of 6 feet to reduce cardiac magnification. Everybody gets it? Okay. Now, some bachas are saying, sir, aur batao. Let's go further now. Let's go further. This is the basics about PA view. PA view is done in inspiration. Immediately, MCQ forms. Can you tell me a reason why you would do a expiratory X-ray? Okay. अभी मैंने बोला ना, ऋषभ, अभी मैंने बोला कि chest X-ray is done in full inspiration. Then why would you do a expiratory X-ray? Anybody? उल्टा हो गया ना. Normally we do inspiratory X-ray. Why would we ask the patient to do expiration and then do X-ray? Remember, if we are looking for a small pneumothorax. Okay, I see very good. Soumya and Chandresh have answered correctly. So if you're looking at a small pneumothorax, sometimes if I take a deep breath, if the lungs are fully expanded, they might compress it. I might miss it. Small pneumothorax is best picked up on a expiratory chest X-ray. Second is air trapping. You might have heard of that if you have air trapping, you need to look at the X-ray in both inspiration and expiration to see if there is any air trapping happening. Okay. Now, once you are clear. Now, Arun is saying it's a diaphragmatic palsy. No, diaphragmatic palsy mein you need to look at it in fluoroscopy because there will be paradoxical diaphragmatic movement, Arun. So that is not seen on a static X-ray. You need to do something dynamic. So we will do a real-time X-ray called as fluoroscopy to look for the diaphragmatic paradoxical movement. Okay. Now, so far so good. This is PA view. Now, anybody, what is lateral view? Okay. What is lateral view? एक बार मेरी तरफ देखो. Everybody look at me. Lateral view means you keep the film on one side and the rays are coming from the other side. I'm keeping the film on one side, rays are coming from the other side. What is this X-ray? Lateral view. What is this X-ray? Lateral view. Okay. Jivesh and Vinay. If you have a small pneumothorax, in full inspiration, sometimes it gets compressed. Pneumothorax कहाँ पे? Pleural space में. अगर lung पूरी तरह से expanded होगी, तो वो कभी हम appreciate ना कर पाए, ऐसा हो सकता है. I'm again repeating. A small pneumothorax might be compressed in a fully inflated lung field, so we may miss it. So it is better to see it when the lungs are collapsed in expiration. Okay. Now, my question to you is this. I look at the X-ray being done. What is the, where is the film? In front of the patient. Where are the rays coming from? Behind the patient. Okay. Okay. आज सिन्हा has asked कि सर अल्ट्रासाउंड नहीं कर सकते बच्चे, अभी आगे बढ़ेंगे, पहुंचने तो दे. Okay. So I am again saying, please, don't run forward and here, stay in the moment. Let's understand what I'm teaching right now. I will teach you everything about the ultrasound appearance of pneumothorax also. But right now I want you to answer this question, beta. The rays are coming from behind. The patient is lying down on his side. The film is in front of the patient. Okay. What X-ray is this? This is called as lateral decubitus. This is called as lateral decubitus. Okay. Now, why do we do a lateral decubitus? Try to understand here. See this is a bottle of water. Can you see a bottle of water? Yes. Okay. I think this is better to show it here maybe. Okay. Now it has some water inside. If I make the bottle lateral decubitus, that means the patient is lying on the side, the water spreads. Similarly, in our pleural cavity, if I have pleural effusion on my left side, and if I make it dependent, if I lie down on the same side, the water will spread and I'll be able to see it easily. Okay, I want you to see this X-ray beta. एक बार देखो मेरे साथ, है ना? Don't mug it up. Try to understand. Can you see there is a opacity here in the dependent side which seems to spread because it is water. When you make it dependent, when we make the patient dependent on one side, if you have pleural effusion, it is spreading. Okay. Now the questions are, why would you do a lateral decubitus view? If you do a chest X-ray PA view, and I'm sure you might have read about this already, but I'll repeat it also, that for pleural effusion we will look at the CP angle. Remember, on a PA view, look at the costophrenic angle. To see pleural effusion on a chest X-ray PA view, we need 150 to 200 ml of fluid. Okay, everybody, are you clear? Everybody, are you clear, beta? That chest X-ray PA view, 150 to 200 ml, clear? Everybody understand? Is required, otherwise you cannot see it on X-ray. But on a lateral decubitus of same side, if I do a ipsilateral lateral decubitus, or maybe I can say of the side of the disease, what will you see? You can see the pleural effusion even if it is as little as 15 to 25 ml. Are you clear? as little as 15 to 25 ml fluid can be seen on lateral decubitus. Immediately a question is forming, beta. I want all of you to answer this question. Best X-ray for pleural effusion is, okay, best X-ray for pleural effusion is, anybody? Is lateral decubitus of the same side. Lateral decubitus of the same side. Clear? But important thing nowadays to remember for all of you is, if they say investigation of choice for pleural effusion, if they say investigation of choice for pleural effusion, then what happens is, nowadays it is becoming so easy that we do a ultrasound of the chest, we see if there is any effusion, you take a needle, ultrasound guided, and do a tap. So that makes sense now that it is better to do a ultrasound as the investigation of choice. What is the advantage? Even less than 10 ml fluid can be picked up in the pleural cavity by ultrasound, and you can do a ultrasound guided tap is possible. Clear? Okay. Everybody understands? Are you able to see the slide now? Okay. As little as 15 to 25 ml fluid can be seen on lateral decubitus, chest X-ray PA view 150 to 200 ml. Okay. Now, one question. Some bachas are writing in the chat box fast, which is not correct, beta. देखो fast करते हैं हम जब हम we do fast when we are thinking of trauma. So wait, I will come to that point. Now I am giving you another question to solve. Investigation of choice for ascites is. Investigation of choice for ascites is. Anybody? Investigation of choice for ascites is. Now see, some bachas are saying, sir, abhi sir has taught us pleural effusion and he is jumping to ascites. What is going on? I will tell you the symmetry in our body. देखो, pleura में पानी, pleural effusion, peritoneum में पानी, ascites. I am repeating in English, don't worry, don't panic. If you have fluid in the pleura, pleural effusion. If you have fluid in the peritoneum, it is ascites. To see fluid, the logic remains the same, so the investigation of choice remains the same as ultrasound. Okay, this is how you develop concepts. A concept means that if I understand it clearly, I can apply it in different diseases. Investigation of choice for pleural effusion and ascites, both of them is ultrasound. Are you clear, betas? And I can see all of you are, running the chat box and putting it on fire. Great. Now, everybody understands? Now, somebody will say, you said, sir, you said that chest X-ray PA view should be done in erect position. What if somebody cannot get up? Somebody is an accident patient. Somebody is an ICU. What will you do? So that makes me understand that bedside X-rays are AP view. Are you clear, beta? Bedside X-rays are AP view. Why? Because the patient is lying down. So now you will not ask the patient to go prone there in accident patient. What you will do is, you will keep the film behind him. Patient is lying down. The rays are coming from the front. Bedside X-rays, road traffic accidents, we do a AP view. Otherwise, most often in the OPD, we do a PA view. Clear? So trauma, bedside, ICU, AP view. Everybody gets it? Interesting? Okay, bitches. So let's go forward now. What I'll do is, because I know that many of you actually want to learn it more clinically, so I'll show you how a chest X-ray really looks like and what should be my approach. I will go clinically, side by side, create MCQs also for you. Okay. So whenever I look at a chest X-ray, everybody listen to me and write down also. First thing I do is, I measure the distance between the spinous process and medial end of clavicle. एक बच्चा बोल रहा है, सर इन्फेंट में या न्यू बॉर्न में, अगेन यू नो इट विल बी एपी व्यू. भाई न्यू बॉर्न को बोलूंगा जाओ सीधे खड़े हो जाओ, सेंस नहीं आ रहा ना बेटा, यू नो अमूल्य, you agree? So infants also it's usually IP view. Okay, young children who cannot be, you know, listening to you, or who cannot be, you know, following your commands, we do IP view. So first thing we do is, we measure the distance between the spinous process and medial end of clavicle. Okay, let's see beta, एक बार देखो मेरे साथ. These are your spinous processes. Okay, and this is where your clavicle is. So we measure the distance between the spinous process and clavicle. This distance, okay, this distance should be equal on both sides. So I'm teaching you how to read a chest X-ray. We will go step by step. This distance should be equal. Distance between the spinous process and medial end of clavicle should be equal on both sides. If unequal, if it is not equal, okay, if the distance between spinous process and medial end of clavicle is unequal, it is called as rotation. It is called as rotation. Okay, then it is called as rotation. Now what do we mean by rotation? Let's try to understand what do we mean by patient rotation, है ना. अभी लिखने की जगह एक बार समझते हैं. Okay, keep your pen down, listen to me, look at the screen. Now see, whenever you are doing a chest X-ray, okay, इतना याद करना है अभी, बस I'm trying to make sure that you understand. Whenever we are doing the chest X-ray, patient should face the film, and both my chest wall should touch the film equally. Okay, everybody, are you able to understand me? Okay, tell me in the chat box. Both my chest walls, right and left, should be touching the film equally. But sometimes as a patient I may be, you know how patients are a little relaxed. Okay, I'm doctor, I'm but patient relaxed. Like patient is standing like this. Okay, I'm standing straight. Now imagine now a patient is standing like this. What is happening? My one chest is touching the film, other chest is away from the film. So this is called as rotation. Rotation means patient is not standing straight, he is slightly rotated his spine. In Hindi हम बोलेंगे कमर को घुमा दिया मरीज ने, मतलब he was supposed to stand straight but उसने घुमा दिया. Okay, so this is called as rotation. Now why is so important? Why it is so important? Let's try to understand. If there is rotation, what will happen? One chest is in contact with the film, one chest is away from the film. As a result, you will have asymmetry in lung lucency. ऋषभ देखो, ऋषभ कह रहा है क्या ये पेशेंट की गलती है? देखो पेशेंट की कभी गलती नहीं होती, गलती हमेशा डॉक्टर की होती है ना. सो वी हैव टू एक्सप्लेन प्रॉपरली. ठीक है ना. एवरीबडी नाउ टेल मी asymmetry in lung lucency. If I say lucency means blackness, kalapan. Now what will happen is if the patient is not standing straight, there is rotation in the patient's posture, one lung will have more black, one lung will be slightly more white. There will be asymmetry. If I don't know all this, I might think there is a disease, I might think there is a pneumonia, and I might do misdiagnosis. Second thing is it might lead to asymmetry in the lung hilum, and it might lead to a false cardiomegaly. Okay, I'm again repeating. The only three things you need to know. First thing is I look at the X-ray and I measure the distance between the spinous process and clavicle. If it is unequal, I assume that there is rotation. So I know that it can lead to asymmetry in lung lucencies, it can lead to asymmetry of hilum, it can lead to a pseudocardiomegaly. Clear? Everybody okay? Now, my question is this. If there is no rotation, what I do is, second thing that I look at, everybody write down. The second thing I look at when I am looking at a chest X-ray, I am reporting a chest X-ray, I am reading a chest X-ray. Second thing that I look at is trachea. Every day after I see the rotation, I look at the trachea. This particular air-filled organ is the trachea. Okay. Now I want all of you to listen to me. I will explain multiple times in the class. Okay, but listen to me right now. If there is a disease, I always look at a trachea and see if it is being pulled by the disease, if it is being pushed by the disease. So in trachea, the position of trachea is very important. Most of the time trachea is central, and physiologically it is slightly towards the right also. So this is the position, this is the normal position of trachea. Okay, are you clear? Able to understand? And then what I do is, after I see the trachea, I look at the aortic knuckle. After I see the trachea, I will show you aortic knuckle. Okay, now this is your aortic knuckle. Okay, now what is aortic knuckle? Let's try to understand. This is where you have the ascending aorta. This must be the location for arch of aorta. Aortic knuckle continues as descending aorta. So what we are seeing on X-ray is, on X-ray I want to imagine the aorta. So this is the location where we have the ascending aorta anteriorly, then the arch goes anterior to posterior, then you have the aortic knuckle which continues as the descending aorta. Okay. Okay, now so this bulge that you see here, this is your aortic knuckle. I want to see if it is normal, if it is enlarged, or what has happened. This looks normal. This is how the aortic knuckle should be. This is aortic knuckle. Now, how we think anatomically and make a diagnosis, I want you to listen to me. I will explain to you. Abhishek is saying se trachea nahi dikh raha. Ye, Abhishek, this dark thing, air-filled thing, can you see this tubular thing? Ye trachea hai. Okay, beta? Okay, now tell me. Now imagine now, suppose this is the place where you have your arch of aorta. From arch of aorta, anatomically you have three branches. You have the brachiocephalic artery, left common carotid, left subclavian. Okay, from arch of aorta you have three branches. Anybody? Can you repeat with me? Brachiocephalic artery, left common carotid, left subclavian. And can anybody tell me what happens in coarctation of aorta? In coarctation of aorta, we have narrowing of the aorta distal to the left subclavian. Just distal to the origin of left subclavian, in coarctation you have a congenital narrowing. So let me ask you a question. I want you not to, go towards the diseases right now. Look at the normal structures first. I'll tell you the diseases later on. But my question to you is, suppose you have coarctation of aorta, what will happen to left subclavian? अगर किसी को coarctation है, तो left subclavian को क्या होगा? Now, if there is a narrowing after the left subclavian will become dilated. That means in coarctation of aorta, the left subclavian is dilated. This dilated left subclavian will cause a bulge above the aortic knuckle. This dilated left subclavian will cause a bulge above the aortic knuckle. Yes? Now, anybody, let's play Tambola together. Anybody, do you see a number here asked in your 2020 NEET PG exam? Which number do you see here for the full line here? That is called as the figure of 3 sign of coarctation of aorta. This is called as figure of 3 appearance of coarctation of aorta. Now you get the logic behind. I'm telling you the why behind. Answer to आपने याद कर लिया था. I'm just telling you the reason behind. Why do we see figure of 3 sign on chest X-ray in coarctation of aorta? It is because there is a bulge because of the aortic arch. Above it, dilated left subclavian also causes a bulge which becomes like a number 3. Figure of 3 sign, coarctation of aorta. Everybody gets it? Okay, beta. I can see many of you are already rocking the show. So For the next house in Thambola, I will show you later on in the class, I will show you figure of 8. But can you recall and tell me, where did I say figure of 8 appearance in brain? Figure of 8 appearance in brain we saw in pituitary macroadenomas. Pituitary macroadenomas. Clear? Everybody understands? Okay. Now, after what we do is, now try to understand. I saw that if the X-ray has been done properly, if there is any rotation or not. I saw the trachea. I will label it again, beta. I saw the aortic knuckle. Okay. Then what I do is, listen to me everybody. Then what I do is, I look below the aortic knuckle. This area. Can you see this small area below the aortic knuckle? Please see beta, यहाँ पे देखो. NEET PG 2019. What is this area? Tell me. Below the aortic knuckle, they put an arrow. NEET PG 2019. People were mugging up hi-fi things. Exam is asking basic. What is this? Pulmonary bay. This is called as the pulmonary bay. Everybody clear? Are you able to understand? Pulmonary bay means this is the area where you have the main pulmonary artery. Are you clear or not? This is the area where we have the main pulmonary artery. So if somebody has pulmonary artery hypertension, this area gets dilated. This is the pulmonary bay. Now, after you see the pulmonary bay, I want all of you to focus your attention to these white structures in the center. Can you see on both sides? On both sides in the center, there is some white thing here. This is called as the hilum, radiological hilum. So below the main pulmonary artery, you have the X-ray hilum. Okay. Now what is this radiological hilum? This radiological hilum is made up of the right and left pulmonary artery, upper lobe veins, and bronchus. Okay. Now look at the hilum on this side. I want all of you just to see it without, just leave your pen for a moment. Just see it here, beta. Isko dekho ek baar. This is the shape of the hilum. I am trying to paint it. This is how the hilum is normally. Okay. This is the right pulmonary artery and this is the upper lobe vein. And if there is a lymph node, if it is having a tumor or a lymph node, sarcoidosis, tuberculosis, you will see this will be bulging and enlarged. So keep it in mind. This is how the normal looks like. In the class, I will show you tuberculosis, sarcoidosis, different MCQs, but this is the normal appearance of the hilum. Okay, this is normal figure. This entire X-ray is all about normal findings. Arnav Jain, ठीक है ना, normal है ये सब कुछ. So in the exam they might ask you, on X-ray, hilum in a normal person, hilar shadow in a normal person is made up of pulmonary artery, upper lobe vein, and bronchus. And if you are a MCQ smart student, you would have appreciated कि lower lobe vein नहीं है यहाँ पे. Lower lobe veins is not written in the choices. Okay, so it is only the upper lobe veins which contribute to the hilar shadow on the X-ray. Lower lobe veins do not contribute to the hilum. Okay, upper lobe pulmonary veins. Clear? Okay, beta. Okay. Now, if I go below the pulmonary bay, below the hilum, I want you to focus on this small area. You will see a very small area sitting here. Below the pulmonary bay on the left side, you see a very small area sitting here. This is the bulge, or this is the area where we have the left auricle or left atrial appendage. I will, don't worry beta, I'll show you everything. But instead of thinking of what I am not showing, see what I am showing to you beta. है ना? देखो. This is your aortic knuckle. Below it you have the pulmonary bay. Below it you have the left auricle. Remember, your atrium has a tubular outpouching kind of a thing called as auricle. So on X-ray, this auricle is touching the is forming this outline here. This is the outline of the left auricle. Okay, and we will use it when I talk about rheumatic heart disease. I will show you why this is important. And below it, everybody now, below it, this entire area is made up of left ventricle. Okay, so left cardiac border is formed by aortic knuckle, pulmonary bay, left auricle, left ventricle. On the other hand, the right cardiac border is formed by, anybody? Right atrium, superior vena cava, inferior vena cava. So if you now notice, what I have done is, yes, pulmonary bay is on the left side, beta, है ना? बिल्कुल ठीक है, Adesh. Now please see and understand. What I am trying to do is, I am using the inside out approach to look at a chest X-ray. I start at the rotation, then trachea. I am bringing my eyes down, but it is kept in the center. I am looking at the aorta, I am looking at the pulmonary bay, hilum, cardiac borders. This is what I am trying to appreciate. After I, so where is the hilum? एक बच्चा पूछ रहा है, सर where is the hilum? अभिजीत, ये hilum है ना, ये वाला दिख तो रहा है, ये वाला, ये जो white center में दिख रहा है बेटा, ये और ये. Okay, hilum is on both sides. So try to understand. Pulmonary bay is where you have the main pulmonary artery. Now this pulmonary artery will divide into right and left branch, na? So right and left branches are forming your hilum. Okay. After I have seen the hilum, after I have seen the cardiac borders, I will see the cardiac size. Now I should look for the cardiac size. How will you look for cardiac size? Anybody? Do you know how to look for cardiac size on a chest X-ray? To assess cardiac size on a chest X-ray, what we do is, we draw a line in the midline. Okay, what we do is to assess, let me take a line ready-made. Okay, so we draw a line in the midline, and then we measure the maximum cardiac diameter on the right side, maximum cardiac diameter on the left side. This is A, this is B. Then we measure the thoracic diameter at the maximum level, T. If I do A plus B, this becomes your maximum cardiac diameter, divided by T, which is your thoracic diameter. What is this? Cardiothoracic ratio. Okay. So I'm repeating for everybody again, and I think most of you were able to pick it up. It's a very common clinical thing, but you know, I am seeing that many times many children are missing out on these common clinical tips, and sometimes they are asked in the exam. Okay, so how will you assess cardiac size on a chest X-ray? We assess the cardiothoracic ratio. You draw the midline, measure the maximum cardiac diameter on the right side, maximum on the left side, add them to calculate the cardiac diameter, measure the maximum thoracic diameter, take the ratio. Now then, if we have to take the ratio, what is the normal? Normal cardiothoracic ratio in an adult is up to 0.5. That means in an adult, heart can occupy up to 50% of the thoracic diameter. If it is more than that, that means you have cardiomegaly. In an infant, this is 0.6. Clear? Cardiothoracic ratio normal in an adult is 0.5. In an infant, it is 0.6. Clear? That means to call it cardiomegaly in an infant, we need a much, a ratio which is much bigger. Okay? Everybody follows this? Okay. Now, let me just repeat it so that you get a hang of the things, and then I'll go further. Chest X-ray, this is how I report chest X-ray every day. I want you to see the approach. I am going from, see everybody, I am writing my checklist. First I see the rotation. Then after seeing the rotation, what did I do? I saw the trachea, then aortic knuckle, then pulmonary bay, then hilum, then cardiac size, and cardiac borders. जोएल जैकरन सिंह यूनिट, बेटा रेशियो की कभी यूनिट नहीं होती ना, वो तो ऊपर नीचे एक ही डायमीटर है, वो तो कट जाएगा ना. Joel, are you clear कि नहीं? You remember in school they told you that ratios will have no unit. Classic pre-medical test MCQ. Okay. So keep thinking. Now my question is, what do we do after this? Now we will go from inside to outside. Now what I do is I evaluate the diaphragm. I look at the diaphragm. Now please see, right diaphragm is higher than the left, that is normal. And I not only look at the diaphragm, I also look below the diaphragm. I want all of you to focus on this. Below the left diaphragm, can you see this gas? This is nothing but the gastric fundus. So there is normal stomach gas is visible below the left. Don't think of this as abnormal. This is normal. So we see below the diaphragm to see for any subdiaphragmatic pathology. But keep in mind that below the left diaphragm, it is normal to see this gastric fundic gas. Everybody gets it? Now when I'm seeing the diaphragm, what I do is I keep going till this area. Okay, everybody now on the chat box, let me know, what could this be? This is your diaphragm, this is your ribs, costal surface of the pleura, diaphragmatic surface of the pleura, diaphragmatic surface and the costal surface. Can you see there is an angle being formed between these two layers of pleura? This is what is called as the CP angle, costophrenic angle. And I can see all of you are rocking the show. That is why I said this is such a pleasure to teach batch. I have seen many batches, so many years, and I have never seen students who are so intelligent as you are. Now tell me, bache, please tell me. This is the most dependent area of the pleural cavity. So if I have to look for pleural effusion, tell me. If I have to look for pleural effusion, where will you look at the X-ray? If you have to look for pleural effusion, I will look for the CP angle. Clear? Clear, everybody? Okay. Now there is a little bit of controversy between why the right diaphragm is higher than the left. Radiology textbooks, they say that in a live person, when we do a X-ray, it is because of the heart pushing the left diaphragm down. Although the anatomy books in cadavers, they differ, but in live person, what we believe is, on a X-ray, heart in a real man is actually sitting on the left diaphragm. So left is actually pushed down because of the heart. This is what the classic radiology teaching is. Okay, everybody gets it? Okay. Now, after I have seen the CP angle, what I drew is, listen to me, I draw a line at the lower border of the second rib, fourth rib, so up to second rib, second to fourth ribs, more than fourth ribs, and divide the lung into upper zone, middle zone, lower zone. Up to fourth rib, up to second rib, I am saying upper zone, 2 to 4 middle zone, below 4 lower zone. And then I compare the two sides to see if there is any pathology. Okay, everybody tell me, if there is a disease in the lung which is appearing white, if there is a disease in the lung which is appearing white, we will say opacity. If it is appearing black, we will say lucency. So I compare the lungs zone by zone to look for opacity or lucency. Okay. Then after I have seen the lung zones, I will look for the bones and soft tissue. I don't want to miss any rib fractures, any flail chest or any other pathology. So I look for the ribs, clavicles and soft tissues. This is what has been called as the inside out approach to a chest X-ray, so that nothing is missed. If you notice, I have seen a lot of structures. I have tried to see the mediastinum also, heart also, aorta also, great vessels also, lungs also, diaphragm also, below the diaphragm also. Clear? This is the approach. This is not a MCQ. This is just a clinical approach. Now what I'll do is, I will ask you to gradually start to learn tiny bits of diseases. Okay, we'll start to see some disease together. Okay, I'm giving you a X-ray to evaluate. Okay. I'm asking you now to look at a X-ray and tell me. Anybody now? Anybody now? Tell me. Okay. Now somebody say ribs. Definitely we look at the ribs. I told you we look at the ribs or any abnormalities. Somebody saying rib count. It's like you may do it, you may not. So it's not like they will never show you X-ray in your exam to count it. Don't worry. My question is this. Tell me. There is a problem on the left side. So what is the problem? It is white. How will you describe? There is a opacity on the left side. Is the opacity causing can you see the CP angle? The CP angle is obscured. Give me just 1 second. I think my surface. Okay, just give me 1 second. I'm just reloading it. Okay. Now the CP angle is obscured. Matlab? Now why would CP angle be obscured? That means that the disease is water. It is going into the dependent part. It could be pleural effusion. And now I want all of you to listen to me. Now suppose you have water in the bottle. If I do like this, or if there is more water, it will spread. So water is causing obscuration of the CP angle, but it is not only there, it is also spreading over the diaphragm. So even your diaphragm is obscured. Are you clear? There is obliteration of the CP angle. There is a opacity which is also obscuring the diaphragm. And also notice that this opacity or this fluid is climbing along the chest wall more than what it is doing medially. Please notice, along the chest wall, along the body wall, it seems to climb up more. Because of the capillary action, this fluid is climbing up more laterally than medially, giving rise to a curve here which is called as the Ellis curve. These are all X-ray findings of pleural effusion. Are you clear? Are you able to answer this? So now I'm again repeating. There is an opacity on the left side which is causing obscuration of the CP angle, obscuration of the diaphragm, and it shows a peak more laterally. It shows a Ellis curve on the top, which are all finding of pleural effusion. Let me try to, we can also say meniscus sign here. Let me try to explain to you that this is where the effusion is. Okay, this is where you have the fluid which is looking opaque on a chest X-ray. So what is your diagnosis on this X-ray? Anybody? We have a patient with left pleural effusion. Okay, now second question coming your way. This is very, very important. I want all of your thinking hats on and tell me. I want all of you to look at this X-ray. I want all of you to look at this X-ray. Now, एक बच्चा कह रहा है सर water white होगा. Definitely. X-ray के ऊपर air will be black, bones will be very white, but if you have any disease in the lung, it will look white. Okay, I'll explain to you. Just give me 1 second. Water will be white. Water is opaque. Okay. Now, do you see there is an opacity sitting here? CP angle is obscured. There is an opacity obscuring the CP angle. That means there is pleural effusion. But what is the difference? This effusion is collected in this area. If you notice, this effusion is like this. It does not seem to flow over the diaphragm. I'm again repeating, listen to me. CP angle obscured है, एक opacity है यहाँ पे, लेकिन it is only till here. It is not going over the diaphragm. ऐसे कैसे हो गया? Why it is not flowing? Now imagine now, I want all of you to listen to me. If I have water in my bottle, it will flow. But if I have pus in the bottle, what is pus? Pus is thick and viscous. Pus, because it is thick and viscous, if you do like this, it will not flow. So what is happening is, if you have a very thick fluid, it will be localized here. This is called as loculated pleural effusion. It could be pus. If it is pus, we will call it empyema. It could be trauma patient with blood, so we will call it hemothorax. Are you able to understand this? Are you able to follow my point? Now somebody is saying, sir, ये mild है, लेकिन ऊपर तो चला गया ना, देखो पानी यहाँ तक तो पहुंच गया, फिर इसके ऊपर क्यों नहीं फैला? That tells me that I am looking at some kind of fluid which is more thick, and that is where I think of, I make my X-ray diagnosis as a loculated effusion, and my DD is blood, pus could be there. Okay, everybody follows? Now also I see one of the bacha, Sneh has pointed out कि sir इसका trachea भी तो देखो, बिल्कुल ठीक बात है. देखो, if you look at the trachea, this is the trachea of this patient. Can you see it is slightly pushed to the other side? Pushed to the other side because of the pleural effusion sitting here. It is pushed to the other side in the previous X-ray. Okay. Everybody understands? Now एक बच्चा कह रहा है सर ये lateral decubitus क्यों नहीं है? Lateral decubitus ना बेटा ऐसा दिखेगा. अभी दिखाया था ना मैंने ऐसे. Ajay Mohan. So lateral decubitus, the patient will be lying down. So it will be shown like this, not erect. You understand? The patient is lying down. This is how the lateral decubitus will be shown to you. Okay. And yes, it could be blood, Aditya, it could be pus, it could be blood in the thoracic cavity or pus. Correct. So this is how we think. Now let's try to think on a CT scan. Let us try to think of on the same condition as a CT scan. This is a CT chest. Okay, CT thorax. I want all of you to just focus on what I am labeling. Lungs, heart, vertebra, and this is your disease. Okay, everybody now look at it and tell me, are you able to think and see that there is a disease here? Definitely there is a disease. Now lungs are black on a CT scan because of air, and vertebra is white because of bone. You remember calcium, bone are white. Now look at the disease. Everybody now, I want all of you to in your mind recall, do a active recall of the Hounsfield scale I taught you. When I was teaching you Hounsfield scale, I told you plus 1000 is bone, minus 1000 is air. What was in between the two? What was in between the two? Water or fluid. Okay, the water or fluid was in between. Now I want today to show it to you practically. है ना? एक बार देखो. Look at the disease. Is it as black as the air? Is it as white as the bone? No, it is in between black and white. आप समझ आया? So you now do you understand? Radiology has shades of gray. This is fluid. This is fluid. Are you able to now understand fluid? Now we cannot say what kind of fluid, but it looks like a fluid. Now, when I see this fluid, I'm thinking in my mind, is it localized or is it spreading? Seems to be spreading along the chest wall. It seems to have a oval elongated shape. It seems to have a oblong shape, telling me I'm looking at pleural fluid. I'm looking at pleural fluid. Okay. Now Nidhi is saying, sir, why is the heart so bright? Because we have given IV contrast. This is a contrast enhanced CT. We have given intravenous dye. So you can see the dye is in the cardiac chambers. My question to you is, all of you, listen to me. All of you listen to me. Once you understand, you will win the game. But एक बार समझना तो पड़ेगा दोस्त. मेरे साथ देखो. Please, everybody see with me. This is your parietal pleura. This is your visceral pleura. Anybody? Everybody, listen to me and answer beta, एक बार देखो, listen to me. The pleural layers are thickened and they are also white, they are picking up the dye. So there is increased vascularity in the pleura and pleura is thickened. All of this is telling me there is some kind of chronic inflammatory process going on which is causing pleural layers to be thickened with some liquid inside. So if you have inflammation around with some chronic inflammation around, some thickening, some fluid inside, that means this is dead bacteria, dead WBCs, that means this is pus. Okay, this is what is called in your medicine as split pleura sign on CT, seen in empyema. Are you able to understand this? That there is fluid in the pleural cavity, but because of my knowledge of pathology, I can see that the pleural layers are thickened, inflamed. That means this is not transudative fluid, because surrounding reaction is there. You can see how thickened the parietal and the visceral pleural layers are. They are bright, they are enhancing, they are vascular, telling me there is some inflammatory process going on. This is how we think when we say this is pleural effusion, this is empyema. Now the problem is, medical students, they think that the radiologists are trying to do the remember the image and identifying it. But what we are doing is, we are doing a step-by-step approach. We'll look at the anatomy, we think about the pathology, come to the diagnosis. And that is how I am trying to teach you to connect the dots. That is why I told you radiology is going to be tough initially, because it is a multi-compartment kind of science. We see a lot of things in the entire body, but that is where the charm of radiology is. I will try to explain it to you. Okay, I will explain it to you. Everybody now look at this image and tell me. Now question is this a normal X-ray or abnormal X-ray? Are we looking at a normal X-ray or abnormal X-ray? Abnormal. Tell me, where is the problem? This is your right side, this is your left side. Where is the problem? Left side. Left side is appearing more black. Are you able to appreciate? It's appearing more black. Now I will explain it to you. I will write it for you. There is hyperlucent. What is hyperlucent? Means more black. What is more black? Hemithorax. I am writing hyperlucent hemithorax. Now anybody now tell me, why would you have a more black thorax if you have more air there? If you have more air, it could be emphysema or it could be a pneumothorax. So this is in my mind that this could be pneumothorax. Now I want you to look at it. What has happened to the trachea and the mediastinum? Anybody? Trachea and the mediastinum are pushed to the other side. Can you appreciate? The heart is pushed to the other side, the trachea is pushed to the other side. And what about the lung? What about the lung? Now this area has no bronchovascular marking. You cannot see any bronchovascular marking. On the normal side in the lung you have bronchovascular markings. And you can see this white area sitting here. This is your collapsed lung. The underlying lung has collapsed. So pneumothorax is, you can even see the ribs are all widened. You can see this is the area where you have the parietal pleura. This must be your visceral pleura. In between you have the air. Okay. Now my question is, why this is a pneumothorax? Because we can see the collapsed lung is outlined by a smooth border which is following the contour of the chest wall. This is called as the pleural line sign. And what is your diagnosis? Pneumothorax. And with such a massive mediastinum and tracheal shift, it is most likely be a tension pneumothorax. Now somebody saying, now try to appreciate beta, heart ये वाला है beta, ये जो ज़्यादा white दिख रहा है, यहाँ पे देखो थोड़ा सा, I am removing my markings. This is the collapsed lung. You can appreciate a border between this and the heart. and you can see the heart is actually pushed to the other side. It has a smooth outer border lined by the visceral pleura, which appears to follow the contour of the chest wall. This is called as the pleural line sign. This is called as the pleural line sign, which is typical of pneumothorax. Okay. एक बच्चा पूछ रहा है why is the collapsed lung white? देखो lung black होती है हवा के कारण. Lung is black because of air. If it collapses, so there is loss of air, it will be white. Okay, I will teach you collapse consolidation also later on. But are you clear? What is pleural line sign? Pleural line sign is the if it is a pneumothorax, if the hyperlucency is because of a pneumothorax, you should be able to see the underlying lung outlined by a smooth visceral pleural line. This is called as the visceral pleural line sign. Okay, everybody understands? Okay, now so far so good. Okay, so far so good. My questions are, can you identify, one bacha was already asking this question, can you identify pneumothorax on ultrasound? Okay, anybody tell me now, can you identify pneumothorax on ultrasound? Anybody wants to tell me? Anybody? Yes, answer is yes. And it has been asked multiple times in your INI CET exam, how to identify pneumothorax on ultrasound. I will teach you. Don't worry, I will teach you. Then I will come to other images, but first I will teach you how to identify. Just listen to me, then I will show you the sign also, better don't worry. If these are your rib cage, chest wall, below the chest wall you have the pleura, and below the pleura we have the lungs. Okay, below the pleura we have the lungs. Now I want you to close your eyes and imagine if this, okay, now open your eyes. If this is your chest wall and this is your pleura, what will happen? When you are breathing, pleural interface is showing a sliding motion with respect to the chest wall. Clear? I am again writing. Normal ultrasound, you should see sliding motion of the lung pleura interface. Okay. Okay. Now anybody can answer this question now. Suppose you have a pneumothorax. Suppose this is your chest wall. Then below the chest wall you have pneumothorax, air, 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 and the lung is compressed somewhere here. Suppose you have pneumothorax sitting here. Now what will happen? Now what will happen is, if there is a pneumothorax here and you do an ultrasound, this pneumothorax will not have that sliding motion that we could see in a normal person. So in pneumothorax, this sliding motion will be absent. Okay. Now it is so important for you to understand that nowadays ultrasound is becoming the first line investigation in ICUs and trauma patients. So we need to identify pneumothorax on ultrasound. Normal lung ultrasound should show sliding motion. In pneumothorax, sliding motion will be absent. Okay. Now let's see how it will be seen on an ultrasound image. In ultrasound, we have a mode called as M mode, which I will explain gradually again when I show you ultrasound, and we'll do those discussions. M mode ultrasound is sensitive to movement or motion. Okay, it is a representation of the movement. So when I do M mode ultrasound, chest wall will show flat lines because there is no movement happening there. All the movement is happening at the lung pleura interface, so this area will become dot 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 because of the movement. So in a normal person, you will see the chest wall will be straight lines like waves, and the lungs will have dots like beach. Together it is like a seashore. This is the normal appearance. If you have pneumothorax, you will have flat lines at the chest wall and flat lines at the lungs also, because the lungs are actually very deep. You have a pneumothorax, so you will keep seeing only flat lines. This is what is called as the barcode sign or stratosphere sign. Okay. Now this time I will repeat once more for Abhijit and everybody who's asked me. Now I will repeat with a real image, and I want you to know this is a direct question that can be asked multiple times in your exam. Okay, please see the first image, beta. Okay, I will try to zoom it. I think it's already zoomed. Okay, just give me 1 second. I'm just getting the system to respond to the high resolution image. Please see here. This is the area where I was telling the flat lines are there. Okay, so these are your waves. These are your waves. You understand? You're sitting on a sea beach waves, and this is the beach where there is movement and all the dots are seen. This is the normal seashore appearance on M mode ultrasound. Compare it with the others. Compare with the next image, beta. Do you see flat lines, flat lines, flat lines, flat lines? What is this? This is your barcode sign seen in pneumothorax. Okay. So the normal appearance on lung ultrasound is seashore sign. In pneumothorax you see a barcode appearance. Now why is all this so important? Why is all this so important? Because nowadays we are doing ultrasound as the first line investigation in a patient with road traffic accident. Have you heard of this? What is the first investigation to be done in a patient with blunt abdominal trauma? Anybody? Anybody tell me? What is the first investigation to be done in a patient with blunt abdominal trauma? We need to do ultrasound. But that ultrasound is called as FAST. What is FAST? Anybody can explain to me? Focused assessment with sonography in trauma. I'm zooming in, beta. What is FAST? Sometimes they ask you to write the full form. Focused assessment with sonography in trauma. And what are we trying to look for? Our main goal is to look for hemoperitoneum. I will explain how it is done and then we will gradually reach to the concepts. What we do is, in the classical FAST, we keep the probe in 4 locations. We keep the ultrasound probe first in the epigastrium in the subxiphoid area. So where do we keep the probe first? In the subxiphoid area. Okay. Now just give me 1 second and I'm explaining when ultrasound is done. FAST is an ultrasound, beta, and we are doing it as the first step in the trauma patient in the emergency. And this is usually done by the emergency doctors themselves, not by the radiologist, because we are usually not available for emergencies. It takes time to get a radiology test done. Radiologists are busy in the hospital, so surgeons are doing it themselves. They keep the probe, listen to me, everybody listen to me, you keep the probe below the xiphoid process and tilt it upwards. Okay, everybody now, we'll keep the ultrasound probe in the subxiphoid area, tilted upwards. What will you see? You're trying to see the heart. But what do you want to see in the heart in a patient who has had a road traffic accident? You want to look for cardiac tamponade. So in FAST, we keep the probe first in the subxiphoid area to look for any possible cardiac tamponade. We don't want to miss a cardiac tamponade. Then what we do is we keep the probe in the right flank. Then you keep the probe in the right flank. Anybody, what do you want to see in the right flank? Very good. I can see so many of you are answering. I'm so proud of all of you. I've already said this. I'm saying it again. You guys rock. You are so smart and so intelligent. It's such a pleasure to teach you all. And now see, if I keep the probe in the right flank, this is where my liver is. This is where my kidney is. Okay. If I keep the probe between them, what am I trying to look for? I am trying to see between the liver and the kidney. That is called as the hepatorenal pouch of Morrison. I am trying to look at the Morrison's pouch. So if you have any blood in the peritoneum, why would you have blood in the peritoneum in a patient with trauma? If there is a solid organ rupture, if there is a trauma patient, some organ has ruptured, there will be blood. So we are trying to look for the Morrison's pouch. Then I keep the probe in the left flank. In the left flank, I try to look for any obvious splenic injury and any blood in the linorenal recess. In the left side, I'm trying to look for any obvious splenic injury or any blood in the linorenal compartment. Then I keep the probe in the pelvis. So I keep the probe in the pelvis to look for any pelvic blood. So this is how you do a fast. But now it is recommended that when we are doing fast, we should extend the study. So when we extend it, it is called as extended fast. When we extend the study, we call it E-fast or extended fast. You keep the probe in the right chest and left chest also. Then you look at the right chest and the left chest also to look for any thoracic cavity abnormality. So we want to also see the thorax. Then we call it E-fast. And that is why it becomes important in trauma patients that we should be able to identify pneumothorax on ultrasound. Are you clear? That in pneumothorax, the normal sliding of lung pleura interface will not be seen, and you will see a barcode or a stratosphere appearance on M mode. Okay. Any drawback of fast? Any drawback of fast is that it cannot grade the injury, and also hollow viscous injury can be missed. Fast can miss, hollow viscous injuries can be missed on fast. Now, suppose you do a fast and the image looks like this. I am trying to give you a visual question. I want all of you to see. This is how they ask you questions in the INI CET or central exams. They try to see the application part. This is a previous image that has been asked in the INI exam, in Institutes of National Importance. This is your liver on the ultrasound. This is your right kidney. This is the ultrasound of the right flank. Okay, fast image. So, and even the retroperitoneal injuries will be missed there. Yes. Now, any one of you can answer better. I want you to look between the liver and the kidney. Can you see this black area? Okay, this black area, I'm trying to put some dots there. This entire black area, this is not supposed to be there. Liver and kidney should be touching each other. Here they seem to be separated by a black zone. This is fluid in the Morrison's pouch. This patient has fluid in the Morrison's pouch. In a patient with road traffic accident, what fluid can be there? Blood. So we will call this as fast positive. This image will be labeled as fast positive. So what does this mean? Fast positive means that there is hemoperitoneum. And why there is hemoperitoneum in a patient with trauma? There must be some solid organ rupture. There must be some solid organ rupture. So now what we will do is, if the patient is hemodynamically stable, what will you do? Okay, tell me, listen to me everybody and answer this question. Very, very important. If the patient has a road traffic accident, if a patient has road traffic accident, you do a fast, and fast, if you have minimum 100 ml of blood in the peritoneal cavity, you can see it on fast. If the fast is positive, that means there is hemoperitoneum. and the patient is hemodynamically stable, the BP and pulse and BP and the vitals are stable, then you should take the patient for investigation of choice, which is contrast enhanced CT. Then you have to take the patient for the investigation of choice, which is a contrast enhanced CT. You will see the grade of injury. You will try to find if there is anything, other injuries, there are multiple injuries or not. If there is any retroperitoneal injury, hollow viscous injury, you do a CCT. However, CT can be done only if the patient is hemodynamically stable. If the patient is unstable and the fast is positive, if the patient is unstable and the fast is positive, then you go ahead and take the patient to the OT for an exploratory laparotomy. Because then you cannot do a CT, because it is very important that CT can only be done if the patient is having hemodynamically stable. If his vitals are falling, if BP is not there, pulse is falling, then that means it is telling you that there is bleeding continuously happening, the organ is bleeding inside the peritoneum. You need to take the patient to OT. Are you clear? Everybody understands? So this is what is called as fast positive. This is what is called a fast positive. Hemoperitoneum is there. And now some of you were getting confused in the previous X-ray when I showed you pneumothorax. Some of you were getting confused. This is the X-ray where I want you to see both the sides. Can you appreciate both the sides look hyperinflated? The diaphragm are flattened. The heart is tubular. But you can still see the bronchovascular markings. There is no visceral pleural line sign seen. There is no underlying lung collapse. What do you appreciate? Anybody wants to make a diagnosis on this X-ray? Okay, I'm writing the findings. By the time you can set the chat box on fire. Hyperinflated lungs, flattened diaphragms, tubular heart. If you do a lateral view, you can appreciate in these patients you can have a barrel-shaped chest, increased AP diameter. What are you looking at? Emphysema or COPD. Okay, are you clear? And this is the kind of X-ray they will give you, clear-cut X-ray to diagnose, nothing, so they will not give you a borderline thing. If it is pneumothorax, it has to be pneumothorax. They will not give you subtle findings in a PG entrance exam. Okay, and always remember, then they might take you to alpha-1 antitrypsin deficiency, or they might take you to a history of smoking. That is up to them where they go from here. But this is the X-ray showing you emphysematous COPD changes. Everybody clear? Okay. Now, just one more image, to go before we, ask you to just recapitulate. Every time you see air in the thoracic cavity, sometimes, it might be in the pleura, but it can be somewhere else also. In our mediastinum, we have hollow viscous like trachea, esophagus. If you have esophageal perforation or tracheal perforation, what will happen? This is your right diaphragm. This is your left diaphragm. Okay. In the okay, those two dots. Which two dots is this baby? Those two dots are maybe some cloth clips or something like that. There's nothing of significance at that in that X-ray. That was bilaterally we had emphysematous changes, pachydenum. And Jayati, tubular heart. Heart was, because both the lungs are hyperinflated, the heart is become more narrow and tubular. Heart, cardiac silhouette is tubular, beta. Okay. Now, so disadvantage of fast is it cannot, grade the severity of injury. It cannot tell you hollow viscous injury. It cannot tell you, it might miss retroperitoneal injuries. Okay. Now, you can see the right diaphragm, left diaphragm, but you can even see the central tendon of the diaphragm outlined by air. This is what is called as the continuous diaphragm sign. Now, why would you see a continuous diaphragm? Why would you see the entire diaphragm? You should see the right and the left, not the central part. It is only possible if you have air in the mediastinum. What should I say? Pneumomediastinum. So they might ask you a direct question. In which condition do we see continuous diaphragm sign? What is the answer? Pneumomediastinum. And this is an X-ray of a child where you can even appreciate these white structures here. Can you see them? These are your right and left lobe of thymus. These are your right and left lobe of thymus. And if you appreciate, you will see it is being outlined by air in the mediastinum. Now, thymus is a mediastinal structure. If you have pneumomediastinum, that will outline the thymus, which is called as the spinnaker sail sign. Everybody, are you able to understand? I am repeating, beta. Name two signs of pneumomediastinum which I have already said in the class. Okay, esophageal perforation, tracheal perforation can lead to pneumomediastinum, air in the mediastinal cavity. Air in the mediastinal cavity will lead to it can lead to a diaphragm being seen in its entire continuity, that is continuous diaphragm sign. It can show you the outline of the thymus gland, that is called as the spinnaker sail sign, or we use the word angel wing sign. Okay, my question to you is this. Any other rare sign of pneumomediastinum that you might have learned in surgery? Now, if there is only a small leak in the esophagus, if suppose there is a very small leak in the esophagus, then the air collects locally between the aorta and the left diaphragm. Sometimes we see the aorta and the left diaphragm, air only at an angle between these two. In a small, if there is a very small leak in the esophagus, this is called as Nucleario's V sign. Okay, so now do you understand? It depends on how much air is leaking. If it is only a small quantity of air, you will see a Nucleario V sign. More than the entire diaphragm will be outlined. If it is a child, even the thymus will be outlined. So these are all signs of pneumomediastinum. This is not ginkgo leaf sign. Harsh, ginkgo leaf sign जो होता है वो किस में दिखता है? वो हमें सिर्फ नाम याद करते हैं. If there is air in the subcutaneous tissue, if you have air in your subcutaneous tissue, then the pectoral muscle fibers are outlined by air. So it is seen in subcutaneous emphysema. Air in your thoracic chest wall. So ginkgo leaf alag hai beta, aap confuse karke. In surgical emphysema, if you see air outlining your pectoral muscle fibers, that is ginkgo leaf sign, but this is Nucleario V sign of pneumomediastinum. Okay, now my request to all of you is, okay, एक बच्चा कह रहा है, नितिका कह रही है कि what is spinnaker? Spinnaker sail मतलब, if this is a boat, on the boat you might have seen you can have a sail like this. Okay, so that this kind of a sail is called as the spinnaker sail. So what they are trying to say is, this is one lobe of thymus, another lobe of thymus getting outlined by air in the mediastinum. We are saying spinnaker sail. Just like the spinnaker sail, on the X-ray we are able to see both the lobes of thymus. That is spinnaker sail sign. Okay, Lakshmi Priya कह रही bat wing. बेटा bat wing बाद में दिखाऊंगा. Okay, now साहिल कह रहा है सर गाड़ी धीरे चलती हैं. चलो, let's see. Let me revise and then we'll discuss. Okay, what we have done so far is, I have told you what is chest X-ray PA view, what is chest X-ray lateral view, and what is the difference between lateral and lateral decubitus. Then I showed you the inside out approach to look at a chest X-ray. I have shown you what is pleural effusion. Side by side I also talked about empyema, pneumothorax, pneumomediastinum, fast and extended fast. Okay, this is what we have talked about so far. Okay, now what I'll do is we can maybe take a 10-15 minutes break and come back. And when you come back, I'll teach you how to look at collapse, consolidation, different signs, some infections, and we'll try to build it up. And just to answer a question that Pauline Karwa has asked, she has asked the first question today. So ginkgo leaf sign hota hai subcutaneous emphysema mein. If you have air in your pectoral, in the subcutaneous tissue, then the pectoral muscle is outlined by air. It looks like a leaf. So we say ginkgo leaf sign. And one bacha is saying कि pleural effusion में भी barcode दिखे नहीं. Barcode is seen in pneumothorax. In pleural effusion, you will see fluid. Fluid will appear different from air on ultrasound. We will talk about that when we talk about ultrasound. Okay. Now, so we can take a quick 15 minutes break so that some people want to have eat something, some people don't want to eat something. I'm okay either ways. 15 minutes later, let's come back and I will then teach you how to look at collapse, consolidation, different signs of pneumonias, and lot of interesting things to discuss about. So please be back. Hanchi, welcome back. And I see, we'll be starting soon with the next part of the chest x-ray. I hope you are all able to follow me. I see some bachas want to sleep early, somebody wants to sleep late, somebody wants to study, but we are going to cover the ground that we want to cover. Today, what we are going to do is, I am going to now take you to the next level in chest x-ray. So far, we have only looked at things like pleural effusion, pneumothorax, fast. Now I will show you how to look at things like consolidation, things like collapse. Both of them will appear opaque on a x-ray. But what is the difference? Okay, anybody? What is the okay, let's see. What is the difference between the two? Now I want you all to listen to me. Collapse means that there is loss of aeration. That means the air in the lung lobe is lost. And because the air is lost, there is also volume loss evident on the x-ray. Okay, collapse ka matlab there is loss of aeration, volume loss. And how will you know if there is volume loss? Because of the pull. That means if a lung lobe is collapsed, it will pull the trachea, it will pull the mediastinum, pull the diaphragm. So all the structures will appear pulled towards the disease. Okay. While on the other hand, what is consolidation? Now imagine now if you have air in the alveoli and that air is replaced by fluid or by pus. So here there is replacement of air by some other fluid like pus. Then what will happen is the volume will be maintained. The volume will be maintained. Are you clear, beta? Why is the volume get maintained? Volume is maintained because there is replacement happening. While in collapse there is loss of aeration, in consolidation air is replaced by something else. So volume is maintained, and that is why here you will have no push, no pull. Clear? So the trachea will neither be pushed nor be pulled because the volume will be maintained. So this is the basic principle. Let us try to understand it with a example so that when we see the image we are able to think. Okay, and I see many of you already are answering the questions. I'm so proud of you. But still I want you to hear me out. Even if you know it, try to hear me out because you will understand better. This is where you have your right upper lobe on a PA view, right upper lobe on a lateral view. Can you see the lower border of the right upper lobe is very smooth? It is very sharp. Always remember, pleural surfaces are smooth and sharp. So what happens is pleura is covering the lung, but it is also going into the fissures. So this is the area where you have the horizontal fissure. So right upper lobe will have a smooth sharp border because of the horizontal fissure. Okay, because of the horizontal fissure. Clear? And what about the middle lobe and lower lobe? Let's try to understand. This is where you have the right middle lobe on a PA view and a lateral view, and this is where you have the right lower lobe on a PA and a lateral view. So let's try to understand again. Now I want all of you to see the difference that we saw pleural effusion. Pleural effusion was occupying space in the pleura, and hence it was causing the push. Remember, pleural effusion, pneumothorax were pushing the trachea and the mediastinum. Now try to imagine for a moment. I am repeating for all of you. I think some of you are joining late, and this is what we have said so far. Okay, nothing more. I said, if there is a consolidation in the lung, what will happen? There will be replacement of the air in the lung by some fluid. So volume of that lobe will be maintained. There will be no push, no pull. If there is a collapse, there will be loss of aeration with volume loss. It will pull. It will be pulling the trachea towards it, mediastinum towards it. Then I said this is the right upper lobe, bounded by a sharp lower border, smooth lower border because of the pleural surface of the horizontal fissure. And then I said this is your middle lobe, this is your lower lobe. Okay, happy? Parul, Muhammad, and everybody who's joining late. Okay, so I'm repeating for you. So clearly try to follow this basic anatomy, that right upper lobe is somewhere here, middle lobe is anterior, lower lobe is posterior. Can you see it here? Middle lobe आगे की तरफ है, lower lobe पीछे की तरफ है. This is very important from X-ray perspective. Middle lobe is anterior, lower lobe is posterior. Everybody follows? Okay. Now once you are able to see this, what we will do is, now with this understanding, although this is very, very basic, we'll try to look at some X-ray and diseases. Okay. I want all of you to look at this X-ray with me. Okay. Try to find the disease. Try to find the disease in this X-ray. Anybody? Opacity. Can you see the opacity? Yes? Yes. So there is a opacity here. This is the opacity in this image. Okay. Now everybody tell me the lower border of this opacity. The lower border of this opacity is very sharp and smooth. It is very sharp and smooth. So if it is so sharply demarcated, this must be the fissure. This is the horizontal fissure. But horizontal fissure was somewhere here. Normally in this patient it is pulled up. The horizontal fissure is pulled up. The lobe is small in size. The trachea is pulled towards the disease. What do you think? Anybody? What do you think is your diagnosis? There is a right upper lobe opacity with pull. There is a right upper lobe opacity with pull. The trachea is pulled. The fissure is pulled. What do you think? There is right upper lobe collapse. This is a X-ray showing you right upper lobe collapse. A triangular opacity in the right upper side with trachea pulled towards it. This is a right upper lobe collapse. Everybody understands, and I see most of you are able to answer it correct also. Kriti, Megha, Priyal, everybody is able to do it. Okay, and I would also request many of you to change your photographs on the in the app by your profile editing also. That will also help me to place you, because in the today's exercise what I'll do is I'll request you to maybe share a photo of you with the class so that I can see you, because I know all of you, Vijay, Lakshmi, Aditi, Kalyani, Aisha, E Nandani. I'm talking to all of you, but I've never seen you, so maybe I can place a face for my next class. So this is the exercise that we'll do. This is the X-ray of right upper lobe collapse. Okay, now second question. Look at the trachea, beta. I think Jivesh is getting confused. Jivesh, देखो बेटा, trachea तो इधर आ रहा है ना, ये है trachea. तो अब बताओ किधर को जा रहा है? ये तो राइट है, इधर ही it is बीमारी की तरफ आ रहा है जिवेश. So the trachea is being pulled towards the disease. It is pull. This is a pull lesion. Okay, now so let's go further. Now how the fissure has went up because of the volume loss. Beta देखो, suppose this is my horizontal fissure. If I have a collapse of the lobe here, the fissure will go up. Fissure is fixed in the center. but periphery can go up like this. This is what has happened. Okay, second question beta, try to see it. Now I want all of you to see this X-ray. Very important question. Again you have a opacity on the right side which has a sharp smooth margin, which has a sharp smooth lower border. So the horizontal fissure is pulled up. The horizontal fissure is pulled up. Trachea pulled towards the disease. Trachea pulled towards the disease. So all of this is pointing towards right upper lobe collapse. There is only one thing which is not fitting in. There is only one thing which is not fitting in. That thing is that the central part of the fissure, the central part of the horizontal fissure is pushed down. That means this particular patient has something heavy in the center which is causing bronchial obstruction and which is leading to the collapse of the upper lobe. What could it be? What could it be which is heavy? So heavy could be a tumor. So this patient probably has a bronchogenic tumor leading to right upper lobe collapse. What do we call this? This is called as golden, described by a man called as Golden's S sign. This is called as Golden's S sign. Are you clear? Are you able to understand this? So what is happening is, try to understand. अगर collapse होगा तो pull करेगा. I'm again repeating, collapse will have volume loss. So the trachea, mediastinum, some other structure should be pulled towards the disease. जैसे पहले वाले में देखो ये, पहले वाले में देखो. So this was the collapse. So this is causing volume loss. So horizontal fissure is pulled up. The lower lobe is slightly hyperinflated. Can you see it is slightly hyperinflated, and then you can even see even the hilum is slightly more pulled up. Everything is pulled because this is collapsing. This is a patient with right upper lobe collapse. While the second case is also right upper lobe collapse, but there is evidence of an associated tumor which is called as golden S sign. The horizontal fissure is not only pulled up, it is pushed down in the center, pulled up in the periphery, leading to a S configuration which is seen in bronchogenic tumors and right upper lobe collapse. Okay. Now Jitendra is saying, sir, ये सिर्फ right पे होगा. Yes, golden S sign is only for right upper lobe collapse. Why not for left? Why not for left? Left side पे we do not have a horizontal fissure. Remember, lung में remember anatomy. Right side पे you have a horizontal fissure and an oblique fissure. Left side only oblique fissure. You don't have horizontal fissure. So such an appearance is not possible on the left side. Now Sundari T Bacha is asking, sir, why are the lungs appearing black? You tell me. Both the lungs are hyperinflated, more black, more air. Even the diaphragms are flattened. What could it be? Now if I want to show you, now this is what you need to know that I've already told you, but I want you to see what radiologists are doing. I am thinking in my mind, this patient has a lung collapse, lobe collapse with a tumor with emphysematous lungs, and his right diaphragm is spuriously high. Can you see the right diaphragm is very high? Can you see? So when I'm thinking, I'll think probably he has emphysema. So can you name one etiological factor which can lead to emphysema also, which can lead to tumor also, cancer also and emphysema also? Smoker. He could be a smoker. And if you have a tumor sitting here, and if you tomorrow you go back to your anatomy book, you will see this is the area where the phrenic nerve also descends. So probably this tumor is involving the phrenic nerve. That is why the diaphragm is also gone up. It's interesting actually. It's interesting actually on how much we can see on an image, and that is what makes the science of radiology interesting. We have to think. The important criteria that I want you to understand is the difference between a good doctor and an average doctor is good doctors are thinking, and an average doctor is using memory. You cannot remember everything, but if you're thinking, you will always win. Okay, so this is a smoker with a bronchogenic tumor with emphysema. Interesting. Let's go forward. Now, let's try to solve this particular X-ray. Very important X-ray, very important sign. I want all of you to see the clavicles in this particular patient. Look at the clavicles in this patient. Now, where are the clavicles in this patient? Anybody? Where are the clavicles? These clavicles, they look little higher than normal. This is now the clavicle are not supposed to be so high up. Okay. Now imagine today, I want all of you to see me here. Okay, just one word is to be written, more to be understood. Listen to me now. Everybody try to understand. Suppose I am standing like this. This is straight. If I go like this, this is kyphosis. If I go like this, this is lordosis. Now suppose the X-ray beam is coming from this side. I keep the film behind me and I am standing in this position. Rays are coming from front. Please see quickly. Rays are coming from front. Film is behind. I am lordotic. This is called as lordotic view. Now, why would you do such a view? Why do we do a lordotic view? Try to imagine for a moment. है ना? Word एक ही है lordotic. कारण बताऊंगा. देखो मेरे साथ. Everybody, wake up. It's morning. Wake up. See, this is your lower lobe. This is your upper lobe. Okay. So what is between lower lobe and upper lobe? Middle lobe. छुपा हुआ है. Middle lobe is hidden between the two lobes. If I make the patient lordotic, what is opening up? If I make the patient lordotic, the middle lobe is seen better. So lordotic view is done for middle lobe pathologies. If I have a suspected middle lobe pathology, I will do a lordotic view. I'll ask the patient to become lordotic when I'm doing an X-ray. Now, if this is a lordotic view, this has been done as a AP projection, that is right, but in a lordotic position, Sona Rajan. So फिर हम इसको lordotic view बोलेंगे क्योंकि AP के लिए तो patient should be standing straight ना. Here he is standing in a lordotic position. Now the question is, where is the problem? Are you able to see this opacity on this X-ray? What is this? There is a triangular opacity on the right side. Now this opacity is, the base of this opacity is touching the heart and we are unable to appreciate the cardiac border here. So I am saying there is a triangular opacity obscuring the cardiac border. What could it be? There is a triangular opacity obscuring the cardiac border. What could it be? Now to answer this question, we need to know a sign in radiology which is called as silhouette sign. Silhouette sign. Have you heard of this before? I will write down. And explain it to you. Okay. First we will write down and then we will understand. Just one line to write down. Silhouette sign says, listen to me. Silhouette sign says a mediastinal border can be obscured only by pathology in direct anatomical contact. Okay. So गोकू तिवारी लॉर्डोटिक व्यू तब करेंगे जब हमें एक्सरे पे शक है कि there is a middle lobe pathology. Then we do it. Otherwise we will not do it. It is not a routine thing. It is a special X-ray done in special conditions. Okay. Now, anybody? Silhouette sign means, listen to me everybody, a mediastinal border can only be obscured by pathology in direct anatomical contact. Now, why is this important? Let's try to understand. एक बार सोचो. ये मेरा sternum. Look at me everybody. Wake up. This is my sternum. Just behind my sternum you have heart. Okay. Just behind my sternum I have my heart. This is where I have my middle lobe anteriorly. Lower lobe पीछे को है. Okay. So lower lobe is posterior. Middle lobe is anterior. Heart is just behind the sternum. So which lobe on the right side is touching the heart? Which lobe is in anatomical contact with the heart? Middle lobe. Lower lobe is posterior. It does not touch the heart. Middle lobe is touching the heart. So that tells me if there is a middle lobe pathology, it will obscure the cardiac border. if it is a middle lobe pathology, just like you see on this X-ray. So this disease is having a base towards the heart, and the cardiac border cannot be appreciated in this area because they are both directly touching each other. So if they ever, I can see most of you already know this also, Abhishek, Vijay Lakshmi, Sudarshan, Rishabh, very good beta. So this is a X-ray of a patient with right middle lobe collapse. What is the sign seen in this image? The sign that you see in this image is called as silhouette sign. This sign is called as silhouette sign. Okay. Sai Kiran is saying, what will be the position of clavicle in kyphosis? So, beta, kyphosis, we never do a kyphotic X-ray, so there's no need to. It will be distorted, and the X-ray itself will be difficult to do. Ek baar sochna, just your question is little theoretic. Somebody is standing like this, so X-ray is to make the film in contact with the patient is very difficult. So X-ray is usually not good quality. Okay, Sai Kiran. Okay, I'm again repeating this silhouette sign. Silhouette sign is a classic radiological sign described by a radiologist called as Felsen. So he said that if a mediastinal border is obscured, that means the disease is in direct contact with it. So if a opacity on the right side of the thorax, of the right side of the lung, is obscuring the cardiac border, that means it is located in the middle lobe. Everybody gets it? Okay, I'm scrolling right left as per your request. Everybody gets it? Okay. Now somebody is saying, why collapse? Why collapse? Very good question. That means there will be something different that will happen in consolidation that I'm yet to tell. So wait for it. When I tell you consolidation, I'll tell about a sign called as air bronchogram, which will help us to differentiate it further. We will get back to that once we reach there. Okay. Now somebody is saying, sir, इसमें pull नहीं पता चल रहा, because middle lobe में usually इतना नहीं पता चलता, upper lobe में trachea का pull ज़्यादा पता चलता है. Clear beta? Okay. Now somebody is saying, will you see this on the left side also? Yes, it is possible to see it on the left side if you have a lingular pathology. If you have a lingular pathology, lingula, remember a segment of the upper lobe called as lingula. If that is involved by pneumonia, then you will have obscuration of the left cardiac border. Okay, so silhouette sign is applicable in any pathology which is in contact with the mediastinum, but this is the classic example. Okay, Seturam. Okay, now let's go. And one bacha is saying, what is Felsen? Felsen was the man who described it. Okay, Felsen was the chest radiologist, chest physician who described this sign. Okay, beta. And Shweta Sangma is again saying, what is RML? RML is right middle lobe, beta, right middle lobe collapse. Okay, now let's go further. Now on the left side, there is a lobe which is shown here. This is your left upper lobe, Now have you ever imagined on the left side, the upper lobe is very different from the right side. It has a tongue-like projection. There is no horizontal fissure. What is this? This is your lingula. So lingula is a segment. Lingula is a segment. These are the segments of the upper lobe. It is not a separate lobe on the left side. Left side पे वो fissure है ही नहीं, horizontal fissure ही नहीं है. So left upper lobe has a lingular lobe, a lingular segments there. Clear? Okay, beta. Now this is your left upper lobe. And where is the left lower lobe? Then you have the left lower lobe, which is bounded in the front by a sharp border of oblique fissure. Okay. Everybody understands? Okay. Now my question to all of you is, imagine, now this is a very difficult question. I need your full focus. Very difficult question. Let's see if you can answer. Somebody has left upper lobe collapse. What will happen? Anybody? Suppose you have left upper lobe collapse. What will happen? If you have left upper lobe collapse, imagine this X-ray. This is your left upper lobe. This is your left lower lobe. Now imagine the left upper lobe is getting collapsed. That means there is loss of air, volume loss. It is becoming small and it is becoming white. Suppose this is your collapsed left upper lobe. If the left upper lobe will collapse, what will happen to the lower lobe? The lower lobe will hyperinflate. The oblique fissure will move anteriorly and the lower lobe will hyperinflate. Okay. Now let us understand the scenario. Okay, I want you to focus on this. This is slightly difficult. Where is oblique fissure and where is the lobe? Now please see here. देखो, ये lateral view में ये upper lobe है, ये lower lobe है, और PA view में ये upper lobe है, ये lower lobe है. थोड़ा सा आगे और पीछे होने के कारण they are looking overlapping to you, बेटा. I see one बच्चा Dubin has asked this question. Now I will ask you a question. Let's see if you can answer. Okay, I'm going back to the X-ray. Just very, very slowly. Don't panic. Very, very slow. Very slow. Relax. Now, anybody now? Suppose you have a left upper lobe pneumonia. Suppose you have left upper lobe consolidation. Then you will see a opacity sitting here. Okay. Now, anybody? My question to you is this. Anybody can answer, beta. Batao. If you have a left upper lobe pathology or a consolidation in the left upper lobe, will you be able to see the aortic knuckle? No, the aortic knuckle will be lost because we are able to see aorta on a X-ray because it is outlined by the air in the lung. अगर यहाँ हवा ही नहीं है तो aorta भी नहीं दिखेगी. Agreed? Agreed? Okay. Now I will show you a picture, and this is very important. If you are able to tell me, okay, just listen to me. I am saying Ahmed, Devanshi, everybody has said कि अगर left upper lobe में pneumonia है तो aorta का shadow obscure हो जाएगा. Okay. Now let's see this X-ray now. Okay, very important X-ray, very difficult even for postgraduate residents. Can you see there is some opacity on the left side? Yes. There is some haziness on the left side. Yes. Now tell me, is this pneumonia or is this a collapse? Anybody? Anybody who's able to tell me, and if you let me know in my Instagram, I'll send you a gift from my side. Is this consolidation or not? This is not consolidation. Yes? Or is this consolidation? Tell me. This is not pneumonia. Tell me why. I'll tell you two reasons. Number one, look at the trachea. Look at the trachea in this patient. Anybody wants to see? Tell me, tell me. The trachea in this patient is here. Let me just bring it here. What do you think? Trachea is pulled towards the disease. Pulled towards the disease. And second thing is, even the lower lobe has been pulled up. And the superior most segment of the lower lobe, let me just bring a color here, is actually outlining the aorta. Are you clear or not? Now I am again repeating. Okay. Now this is not pneumonia because trachea is pulled and I can see the aorta. I should not be able to see the aorta. What is happening here? Here the aortic knuckle is outlined. It is very difficult. Listen to me. Is outlined by hyperinflated superior segment which is shaped like a sickle of the lower lobe. Are you able to understand my point? This would not happen in pneumonia. So there is clear-cut evidence of pull. That means this opacity is having volume loss. It is pulling the lower lobe till the aorta. It is pulling the trachea, and that is why this is the X-ray of left upper lobe collapse. Not pneumonia. This is left upper lobe collapse. Are you clear? Many times I see first year PG, second year PGs might be missing this lesion. Very important. Now, because this is so important, it has been given a name. This is a air-filled hyperinflated segment outlining the aorta. Air in German is called as Luft. Sickle is called as Sichel. This is called as Luft Sichel sign. Okay. Air-filled sickle sign or Luft Sichel sign. Are you able to understand my question? Okay. Are you able to answer? So in your exam, they will say Luft Sichel sign on chest X-ray is seen in. The answer is left upper lobe collapse. Why this is collapse? Why not consolidation? Why this white thing is not pneumonia? Because I can see two evidence of volume loss. Trachea is pulled towards the disease, and even the aortic knuckle has been outlined by the lower lobe segments. Because in pneumonia, if you have a left upper lobe consolidation, you should not be able to see the aorta. Here we can see it, telling me that there is something which is hyperinflated reaching to that level. Are you clear? Now, one bacha is saying how to differentiate from fibrosis. See, fibrosis in the lung lobe is also a kind of collapse. If you have fibrosis, it is going to cause the collapse of the volume. It will lead to reduced volume of that lobe. So that will also behave like a collapse. Yes, and even the diaphragm looks a bit pulled. That is correct. Okay, where is the sickle shape? Is a very good question by Kazi Ronak. So let me draw it for you. Beta, ये वाला है. ये वाला sickle shape है. देखो. Okay. अब मैं इसको मिटाऊंगा. यहाँ पे देखना है आपने. This is the place where you have to see, beta. Suryavanshi, beta, this is the place where you have to see. Can you see this? A sickle-shaped air shadow outlining the aortic knuckle, which is telling me that the superior segment is hyperinflated, superior segment of the lower lobe is hyperinflated and forming a sickle-shaped boundary to the aortic knuckle. That is called as Luft-Sichel sign. Yes. So this is how we differentiate a left upper lobe consolidation from collapse. A consolidation, if it is a left upper lobe consolidation, it should obscure the aortic knuckle and the trachea will not be shifted. Here I can see a opacity, but I can see the Luft-Sichel, I can see the tracheal pull. I know this is left upper lobe collapse. Okay, difficult concept, but I think most of you were able to pick it up. Okay, how do we know it is lower lobe? Now this is, we need to remember this, that there is an opacity here, so it could not have been upper lobe because that is already opaque. So then how it is outlining it? Can you see? And you can see the disease is white. देखो जो upper lobe है वो तो सफेद हो चुका है ना, तो फिर ये dark सा क्या आ गया जो aorta का outline कर रहा है? वो lower lobe का part है जो ऊपर तक आ गया है. Okay, okay. What does Luft means? Luft means air. Shreyansh Soni, जैसे आपने you must have heard of an airline called as Lufthansa. So Lufthansa airline is a airline from town in Germany called near Frankfurt called as Hansa. So Luft means air, air Hansa, Lufthansa. Okay, clear? Luft means air. Clear? Okay, now we go forward now. So left upper lobe collapse is very difficult to diagnose on an X-ray because there is no horizontal fissure. So that border, Kruti, that border that we saw on right, which was so easy, is very difficult on the left side because there is no horizontal fissure is not there. Okay, now let's go further. This is very, very important, very interesting. Previous image has been asked in your exams. Let's see how many of you are able to answer. Ye trachea beta. So this is the trachea of the patient. What do you think? Trachea appears central. That means there is no volume loss. There is a opacity, but the trachea is central. Okay. So what are we thinking if the trachea is central? No pull, no push. I am starting to think that I am looking at consolidation. Now, how will I confirm? How will I confirm? Okay, how will I confirm this is consolidation? The sign that is important that I was talking about, there is a sign that we see in consolidation, but we don't see in pneumonia, we don't see in collapse and pleural effusion. That is called as air bronchogram. अभी दिखाता हूँ, फिर बात करते हैं, ठीक है? Now I want you to, I'm zooming the image and I want you to look at this area. अभी देखो इसको, सबके सब, okay? And this is the photo that we will all take together. Okay, now anybody who could take this picture, share it with me for a gift. Now tell me, can you see these are the air-filled bronchi? So the disease is white, but it is not totally white. Okay, good morning, get up, get up. It is not totally white. Beach mein, you can see tubular air-filled bronchi. Tubular air-filled bronchi. This is called as air bronchogram. This is called as air bronchogram. Now why it is developing, I will explain it to you. And then we will try to solve the causes. Now suppose this is your bronchus and these are your alveolar ducts and alveoli, alveolar duct, alveoli, okay, and in between you have the bronchus. I will zoom it, don't worry. Now imagine now, everybody try to imagine now, suppose you have some infection, some bacterial infection, some pyogenic infection in the lung, and as a result of that infection there is some inflammation happening here. That inflammation is causing capillaries to leak. There is fight happening between our neutrophils and the infection, forming exudative fluid, and the infection is spreading and inflammation is also spreading, so exudates are filling up the alveoli. Alveoli are interconnected by pores of Kohn, so the exudates are all spreading. So what is happening here? The alveoli, listen to me, alveoli, the alveolar air is getting replaced by inflammatory exudates. So what will happen is, I want you to imagine this on X-ray. All of you listen to me. This entire diseased area will appear white because the alveoli are filled up with fluid. But the bronchus is patent, so you will see tubular air-filled shadows in between. That is called as air bronchogram. Are you able to understand this? So air bronchogram is happening in pneumonia. Tell me why. Okay. Anybody tell me, why do you see air bronchogram in pneumonia? Tell me why. Because of the alveoli are filled up with exudates. Inflammatory exudates in the alveoli. Okay. Now second question. Let's see if you can answer. Okay. Second question is, will you see air bronchogram in a patient with ARDS? Will you see air bronchogram in a patient with ARDS? Anybody? ARDS mein kya hoga? Now what is ARDS? I am sure many of you heard about ARDS during the COVID pneumonia or the COVID pandemic phase. So ARDS is a systemic inflammatory response. You have a disease which is triggering inflammatory response in the lungs, and the entire lungs have inflammation and the capillaries are leaking fluid into the alveoli. So ARDS is causing an exudative edema in the lungs. The alveoli are getting filled up. Because it is causing edema in the alveoli because of systemic inflammation, again the alveoli will be opaque, but the bronchus is patent. You will see air bronchogram. Third reason for air bronchogram in a preterm infant, anybody, a preterm newborn, is hyaline membrane disease. Hyaline membrane disease that you will read about gradually in your pediatrics class also. If you have a preterm baby will have lack of surfactant, and the alveoli will collapse if there is lack of surfactant because of the surface tension. So alveoli will collapse, but the bronchus is cartilaginous. So the bronchus will remain patent because it is cartilaginous, so you will see air bronchogram. So I am again showing you the concept. Listen to me, beta. I will show you the concept, but you will have to listen to me. The concept is, air bronchogram is seen whenever you have a disease involving the alveoli, but the bronchus is patent. And if you now see, these three diseases on X-ray are connected with an invisible thread. And if you see this thread, this is concept. All my life I've been seeing that any people who get top rank in the exam, they will say concept banana hai. But the other junior students are saying banana kya hai? What is concept? Concept is an invisible thread which connects the dots so that you don't need to remember them. Once you get the concept is, HMD is hyaline membrane disease, beta. The concept is, if a disease is causing alveoli to become opaque, either they are full of exudates, or they are full of edema in ARDS, or they are collapsed in hyaline membrane disease, but the bronchus is patent, you will see air bronchogram on the X-ray. My question to all of you is, okay, this is what is called as concept. Okay, and I have seen many people use this word loosely without truly understanding what is concept. Concept is, once you understand this, you don't need to remember. The key word is the bronchus should be open. My question is, suppose you have a bronchogenic tumor sitting here. Suppose you have a bronchogenic tumor, what will happen? उसके आगे का लंग को क्या होगा? Suppose you have a bronchogenic tumor, the lung distal to it will collapse, and even the bronchus will not have any air because the bronchus is closed. So air bronchogram is usually absent in bronchogenic tumors. Air bronchogram is usually absent in bronchogenic tumors because the bronchus is closed. Okay, so this is the air bronchogram that I was talking about, Manushi Supriya, that you can see within the opacity. You are able to see some tubular bronchi because the bronchus is open, alveoli have become opaque because of a pathology. Clear, beta? Everybody understands? Okay, beta. Okay. But there are some exceptions. There is a lung cancer called as adenocarcinoma in situ. Earlier it was called as bronchoalveolar carcinoma. Earlier it was called as bronchoalveolar carcinoma. Okay. This is a typical tumor where the bronchi are not closed. Adenocarcinoma in situ is a type of lung cancer where bronchial obstruction is not there. So here air bronchogram can be found. So don't get confused. Usually in lung cancer air bronchogram is absent. Adenocarcinoma in situ is an exception. One bacha is saying, what about alveolar proteinosis? I would say, Kruti, wait for my discussion on that. I will explain what will you find in that disease. Okay. Now I am going to give you a question. Let's see if you can answer, beta. Question is, suppose you have an alcoholic who has fever and sputum production, an X-ray shown to you. Okay. Let's try to solve, beta. Let's try to solve this simple question. You might have read about this in microbiology also. This is the X-ray, this is the history. Alcoholic, fever, sputum production. Anybody wants to answer this question now? What is happening? Now, definitely there is an opacity here. I don't know what it is, but there is an opacity here. The history is saying inflammatory response is happening, fever is there, sputum production, some infection is there. But here there is a very, very interesting thing that I want you to see. Now, the interesting thing is, I'm zooming the X-ray. Whatever this opacity is, it is very heavy. How do I know it is heavy? It is causing bulging of the horizontal fissure. Can you see? Horizontal fissure appears to bulge down. वो नीचे को दबा हुआ है. That means whatever this infection is, why infection? The patient has fever, sputum. Whatever this infection is, it is causing so much inflammatory response that there is so much exudates in the alveoli that the lobe is heavy and it is causing bulging fissure sign. What infection am I talking about? This is Klebsiella. Klebsiella pneumonia has predication for upper lobe. Okay, so this is Klebsiella pneumonia, upper lobe predominant, more common in alcoholics and diabetics, and the sign is called as bulging fissure sign. Everybody understands? Okay, now what I will do is I'll show you one more interesting thing. Okay, very, very interesting, but I want your patience. Okay, I don't want you to be a clock gazer and you say, "Char kab bajenge." I want you to listen to me. Now see, and everybody understand. Suppose this is your bronchus, alveolar ducts, and these are your alveoli. Now I will name some processes. Let's see how many of you are able to answer, beta. ठीक है? एक बार बताना. Suppose you have a viral pneumonia, or mycoplasma pneumonia, or pneumocystis pneumonia. Okay. Okay, some viral pneumonia, mycoplasma pneumonia, PCP pneumonia. Okay. Or you have some occupational dust exposure. Okay. Or maybe you have some dust exposure. What do you think? Now what happens is, in these patients, the inflammation that happens happens in the connective tissue of the lung. So what happens in this patient is, inflammation, instead of producing alveolar exudates, it produces edema in the alveolar walls. So the problem is more in the interstitium. Are you clear? So you will see edema in the alveolar walls. Everybody follows? Clear? Now, how will I look at it on the X-ray and know that there is a problem which is interstitial? Now, I want all of you to look at it. एक बार देखो मेरे साथ. एक बार देखो बेटा. Can you see there will be air in the alveoli because alveoli are not filled up with exudates and the alveolar walls are edematous. So if you look at it, it looks like a net. दूर से देखोगे ना ऐसा लगेगा जाल है, बीच बीच में हवा है, ये thicken हो गया दिख रहा है, this is thickened, this thing looks like a net. And if I want to impress you with my English and Latin, I'll say reticulum के जैसा लग रहा है. Remember, net in Latin is called as reticulum. So this is called as reticular opacities. Are you able to understand this? So PCP was pneumocystis pneumonia, Bindu Madhuri beta. PCP is pneumocystis pneumonia. I'll explain it to you. But are you clear or not? Are you now able to see the genesis of the word reticular opacity? It's like a net. So how does it look like? I want you to see this X-ray. I want you to see this X-ray. I'm zooming the, both these sides have, some line. I'll zoom it and show to you. Can you see over this area? Entire lung. Please look at this area. Looks as if there is a tiny net-like, fine net-like opacities overlying the lung. This is what, how will I say? I will say this patient has reticular opacities. Okay. Then how they will make a question? Suppose they make a question like this. See two questions. Let's see how many of you are able to answer this question. HIV positive patient, CD4 count less than 200, chest X-ray shows reticular opacities and pneumatocoel formation, no pleural effusion, no lymph nodes. Okay, what could be your diagnosis? So as soon as they say HIV positive, reticular shadowing in the lung, perihilar, central reticular shadows, no pleural effusion, no lymphadenopathy, pneumatocoel formation, these are all findings of pneumocystis jirovecii pneumonia. Okay बच्चे, जो PCP पूछ रहे थे अब समझ आ गया? Pneumocystis jirovecii pneumonia. So this is how they create a question, but key word here in radiology is reticular, interstitial problem. Clear? I will give you one more question. This is for distinction now. Let's see how many of you can answer. And the drug that you will use will be cotramexosol. Okay, very good, Bhargav. Now tell me, my question to you is this. If a patient has reticular opacities in the lung with a small mouth, what will you think? Microstomia reticular. So there is something happening in the interstitium. Some interstitial problem with a small mouth, some fibrosis, sclerosis is happening, small mouth with ILD. What will you think? Then you think of scleroderma. Then you will think of scleroderma. Very good. I think Sahil Arora got it first and Ankita also got it. Very good, beta. And then you think of scleroderma as the cause of ILD. ILD with small, we think of scleroderma. And this is one of a typical question that has been asked in your central institutes in the past. Okay, very good. Now see, now I will now take you further into the concept. Okay, so we are not doing anything mugging up, we are just enjoying the concept. Suppose this interstitial problem continues for a long time. Suppose you are working in a sand mine, you are again and again getting exposed to the dust. What will happen? This entire inflammation will start becoming chronic. So there will be thickening, fibrosis, the air space will become smaller, the wall, interstitial wall will become thickened. Okay, what will happen? So what happens if you have repeated exposure to the cause, what is causing this inflammation, it will become chronic. And when the inflammation becomes chronic, you develop fibrosis. And when you develop fibrosis, you develop thickening fibrosis. And this entire thing in pathology is called as honeycombing. Have you ever thought of this before? Honeycombing. So what is honeycomb? Honeycombing. Are you clear? Clear? Everybody understands? Honeycombing means when there is end stage fibrotic changes in the lung. So the air space will become thickened and the wall will become small and wall will become further thickened. Now, my question to you is, okay, Vaibhav Shukla, that LN that I had written was lymph nodes, no lymph nodes. In pneumocystis, you don't have lymph nodes. Now, what I'm trying to say here is, this X-ray showing you some reticular opacities could be interstitial lung disease, but I'm not sure. Okay, I'm not sure what is it, do I have honeycombing or not. What I'm trying to tell you today is, chest X-ray is inadequate for ILD evaluation or characterization. Okay, I'm again repeating. चेस्ट एक्सरे अपने आप में काफी नहीं है ILD को कैरेक्टराइज करने में. चेस्ट एक्सरे इज नॉट एनफ. सो अबे माइक्रोस्टोमिया आई सेड वाज स्मॉल माउथ. स्टोमिया मतलब माउथ होता है बेटा, स्टोमा माउथ. ओके, honeycombing is a feature of a chronic process happening, end stage lung disease, then you will see honeycombing. So chest X-ray is inadequate. So how will you do? What is the investigation of choice to characterize interstitial lung disease? You need to do a HRCT. What is the investigation of choice? High resolution CT of the lung. You take very thin sections of the lung. Normally when we do CT of the chest, we take around 10 mm or 8 to 10 mm sections. In high resolution CT, we take 1 to 2 mm sections of the chest. And what will we see? Let me explain to you what kind of clinical scenario is this. This is going to be tough, but it is important that we touch upon all the topics. Not just easy, we want to touch upon tough topics also. So listen to me. Suppose you are sitting in your clinic. And you have a patient who is a smoker. Let me just get it back. Okay, suppose you have a patient who is a smoker with a chronic history of breathlessness, 6-month history of breathlessness, dry cough. So it is non-productive dry cough. And chest X-ray is having reticular appearance. Pulmonary function test or spirometry is showing restrictive pattern on spirometry. You have advised HRCT for characterization. Okay. So this is how a typical question will come when they make a clinical vignette. They have a longish history of breathlessness, dry cough. Chest X-ray and the pulmonary function test are both pointing towards interstitial lung disease, and a CT has been done. So what is the investigation of choice to characterize ILD? Investigation of choice, okay, I am going slow, Sailesh. Investigation of choice to characterize interstitial lung disease is high resolution CT. Okay. HRCT या NCCT अलग है. HRCT में सेक्शन का थिकनेस बहुत हमने थिन लिया है. विघ्नेश्वर, HRCT we have taken 1 to 2 mm thick slices. How will it look like? I will explain. PFT is pulmonary function test or spirometry. Okay. I'm sure in physiology they must have told of obstructive pattern, restrictive pattern, है ना? Connect करना है, dots को connect करना है. The interesting thing is that when you start connecting, you will start enjoying, है ना? लेकिन ये मत करो कि दूसरे कनेक्ट कर पा रहे हैं तो मैं नहीं कर पा रहा, अरे ये क्या होगा? कोई बात नहीं, आप भी कर पाओगे. Let's keep focusing. Okay, anybody now tell me. Now I want you to look at the CT. This is a HRCT which is having very sharp details in the lung parenchyma. Because the section is so thin, we can appreciate the details of problem happening in the lung parenchyma. This is your heart. That means the section has been taken at this level. So heart hoga, uske upar vessels hongi. So if I take a section at the upper lobe, I should see the superior mediastinal vessels. Here I see the heart. So this must be your lung base. And I want you to focus on this area. Everybody focus on this area. बेटा सिर्फ इसको देखते रहो. Can you see there are round spaces, black spaces with thick walls, one over another, cysts sitting over one over another, stacked, non-communicating. This is what is called as honeycombing. So the HRCT is revealing basal honeycombing. So the lung base is having honeycomb appearance. Okay, clear? So मोहित honeycomb दिखता है interstitial lung disease में जब वो severe variety है, वही मैं बताने की कोशिश कर रहा हूँ. सुनो मेरी बात को. Now I want you to look at the bronchus here. Everybody now. ये समझ नहीं आएगा मेडिसिन में, नहीं तो अगर नहीं सुनोगे तो, है ना. मेरी सुनो मेरे साथ, है ना. Look at the bronchus here. Now what is honeycombing? I've already said honeycombing is a result of end stage chronic inflammatory fibrosis. This is all, fibrosed. So if there is fibrosis, fibrosis will pull. So if this is your bronchus, and if I pull the bronchus, it becomes dilated. Can you see this bronchus is appearing dilated? In the area of the honeycombing, bronchus is dilated. How do I write this complex thing? I will say this is traction bronchiectasis. Traction, खिंचाव के कारण bronchiectasis. Okay. Now tell me what is happening here. Anybody? This pattern of interstitial lung disease is now described as UIP. What is UIP? Usual interstitial pneumonia. That means there are end stage interstitial lung changes like honeycombing in the lung base, traction bronchiectasis. What does this indicate? Poor prognosis. What does it indicate? Poor prognosis. Now, this is the heart. Okay, don't worry if some of you are not able to identify where is the heart. Don't worry. I will teach you when I reach that section. I will teach you also. Don't worry. Okay. जिवेश बेटा देखो, ये जो फाइब्रोसिस है ये इंटरसीशियम में हो रहा है, ये लंग की कनेक्टिव टिश्यू में हो रहा है, इस कारण से हनीकॉम्बिंग हो रही है. एयर स्पेस दिख रहा है, आसपास की वॉल में फाइब्रोसिस है. दिस इज हनीकॉम्बिंग. And if you have any thought process, you can always read it up in your pathology book. It was already there in pathology. I'm just correlating the dots for you. Okay. So if you see honeycombing, traction bronchiectasis, this is UIP. Now the exact important thing that you have to understand, if the history is similar, 6-month history of breathlessness, or they give a history of breathlessness, dry cough, but the image is this. If the image is this, then you will say ground glass opacity. So if in a patient with suspected interstitial lung disease, if you see ground glass opacity in the lung base not reaching, listen to me, not reaching till the pleura, not reaching till the pleural surface, so it is having subpleural sparing, then it is called as NSIP. Then it is called as NSIP, non-specific interstitial pneumonia, which obviously will have better prognosis than UIP, because you don't see those honeycombing and traction bronchiectasis and the end stage changes. UIP is usual interstitial pneumonia, NSIP is non-specific interstitial pneumonia. These are patterns of interstitial lung disease. These are not causes, है ना. हमें नहीं पता क्या कारण है, लेकिन उस कारण से अब ये हो चुका है. जस्ट लाइक इसको लिवर में सोचो, सिरोसिस हो गया लिवर में. So it could be multiple causes, could be, but the end result is cirrhosis or fibrotic end stage liver disease. Here what is happening in the lungs is UIP. UIP is usual interstitial pneumonia. It is end stage of a interstitial process that is happening, which tells you that now there is poor prognosis. You might see it in, like rheumatoid arthritis patients also, or multi-system disorders, idiopathic. So this is how it looks like. The key word is UIP. UIP is honeycombing, basal honeycombing, traction bronchiectasis, poor prognosis. HRCT is the investigation of choice to characterize interstitial lung disease. If you only see basal ground glass opacities with subpleural sparing, then we call it as NSIP, non-specific interstitial pneumonia, which will be ground glass opacities. Okay. Now some people want to know about COVID also. Don't worry, I will also tell you COVID also, don't worry. Okay, clear? Now what is subpleural sparing? एक बार देख लो मेरे साथ, देखो ये जो opacity दिख रही है white white, can you see between the pleura and the opacity there is some normal lung? That means the disease is not reaching till the pleural surface. This is called as subpleural sparing. It is characteristic of NSIP. Clear, Khushbu? Okay. Some people are saying, what about the COVID? Don't worry, I'll talk about COVID also ultimately. Don't worry. Now, some, let's see some, few more easy X-rays, and then we'll call it a day. Few more easy X-rays, then we'll call it a day. Okay. Now, anybody? देखो हनीकॉम अलग है बेटा, सॉल्व देखो हनीकॉमिंग ये वाला है, देखो एक गोल गोल दिख रहे हैं, एक के ऊपर एक बैठे हुए. This is honeycombing. Ground glass opacity is just a haziness, then we call it ground glass. यहाँ पे भी देखो हल्का सा hazy दिखेगा, ground glass. Now what is ground glass, Santanu? Let me explain. I'll explain it with COVID again, don't worry. Ground glass opacity means if there is slight haziness in the lung parenchyma, but you can still appreciate the lung architecture. It is not as white as pneumonia would be, है ना. Pneumonia तो एकदम white होता है ना, उससे कम white होगा. Okay, now let's see. So Ahmad is saying continue, so I am listening to him. And now tell me everybody. Now suppose I want you to look at this particular X-ray, and I tell you, suppose you have a patient who has a old tubercular cavity. Okay, suppose you have a patient who has a old tubercular cavity. This is like a cavity. What is the risk? You have a fungus which is ubiquitous, which is called as aspergillus. If you have an old cavitatory lesion in the lung, it can act like a place where the fungus can colonize. So what can happen here? You may develop a fungal ball inside. This fungal ball, if it is formed inside, is called as aspergilloma or fungal ball. Okay. Now this fungal ball is actually developing within a cavity. So because it is within a cavity, it is taking the round shape. But it is not attached to any wall. It is not attached to the wall of cavity. It is added into it. So you can see surrounding the fungal ball, you should be able to see air. Now I want you to see the X-ray. Now see this X-ray here. This white thing is the fungal ball. Surrounding it, you can see a black rim of air. Can you see it here? Telling you that this is a fungal ball. Fungal ball कैसे पहचानोगे? गोल का, it will be round like a ball, white, but surrounding it you will see the air from the cavity telling you that it is a intracavitatory fungal ball. This appearance is called as Monod sign on chest X-ray. This appearance is called as Monod sign on chest X-ray. Always remember, fungal ball will move with change in position. That means if we change the position of the patient, if the patient moves, this ball will move because it is not attached to any wall of the cavity. Okay. Now, second question is, this aspergillus, the spores of the aspergillus, sometimes they cause an allergic response, especially in people who have asthma or cystic fibrosis. Suppose somebody has asthma or somebody has cystic fibrosis. These people can have an allergic response to aspergillus, which is called as ABPA. What is ABPA? Allergic bronchiolitis pulmonary aspergillosis. How will you identify this on a X-ray? Okay. How will you identify ABP on a X-ray? Anybody? I will explain, beta. I will explain. Suppose this is your lung and these are your bronchi. Okay. Now my question to all of you is, everybody listen to me and tell me एक बार, है ना? Suppose we have allergy. In any disease, you have allergy. What happens if I have allergy in nose? More secretions happen. Similarly, if you have allergy in your bronchus, the bronchus will start to secrete more. And what will happen is, your bronchus will get filled with mucus. This bronchus which is filled with mucus will be called as bronchocoel. Okay. Okay. So the bronchus will be filled with mucus, and when I see it on the X-ray, I want all of you now to see this X-ray. I want you to focus on this area that I am trying to paint for you. Can you see this bronchus? White. Why it is appearing white? Because it is filled up with mucus. It is dilated with mucus. Okay. And when I look at it, it looks as if these are the fingers, but they are thicker than a finger. So somebody must be wearing a glove. This appearance is called as gloved finger appearance. So in ABPA, now you know what is happening. In allergic bronchopulmonary aspergillosis, because of the allergic process, the bronchi become plugged with mucus and they appear like finger-like opacities on the X-ray, which is called as gloved finger appearance. Everybody understands? Now suppose this allergic process is going on for you for a long period of time and it is a chronic disease. So chronic disease, what happens is, because of the mucus plugging of the bronchi, it causes obstruction and the central airways start to dilate. Central airways start to dilate. I will show you a CT scan. Just give me 1 second. Okay. Now I want all of you to appreciate. Can you see these are the dilated bronchi, but you only see them in the center, not in the periphery. You have only central, predominantly central bronchiectasis. Anybody now? So what do you see? Okay, everybody remember, in patients with chronic ABPA, you will develop central bronchiectasis. Central airway will be dilated. This is how it looks like. I'm zooming in to show you. Central airways are having gross dilatation. Periphery are not dilated. This is called a central bronchiectasis. Many times directly they will ask you a question in the exam. Central bronchiectasis is seen in. What will you mark as the answer? You will mark allergic bronchopulmonary aspergillosis. Okay, and I can see, I think Rohin and Vijayalakshmi and Sarthak already could solve it. Now my question to you is, third problem that can happen with aspergillus is, okay, let's see if you can answer. Let's see if you can answer, beta. Aspergillus में ना क्या होगा? देखो, suppose you have a patient who has recently undergone a bone marrow transplant and has neutropenia. What can happen? Now aspergillus is a ubiquitous organism. It is present everywhere, but it cannot invade my lung. But now what is there? There is an opportunity of neutropenia. So what will happen? Tell me. It is an opportunistic infection. Then you can have angio-invasive aspergillosis. So this is slightly confusing, but always remember, in immunocompromised patients with neutropenia, you can have angio-invasive aspergillosis. So when we look at a CT scan of this patient, if you look at a CT scan of the patient, aspergillus infection will cause consolidation because of the infection. but this infection will also invade the surrounding blood vessels. So because it invades the surrounding blood vessels, surrounding it you will have hemorrhage. So there will be central consolidation or central opacity because of consolidation, surrounding ground glass opacity because of hemorrhage, because it is invading the blood vessels. This is called as CT halo sign. Okay, and this can happen without a tubercular cavity, Gaurav, because this is an opportunity given to the organism by your neutropenia. So this is a angioinvasive aspergillosis causing a consolidation with surrounding hemorrhage. This is called a CT halo sign. Okay, now, but when this is resolving, okay, slightly little bit more to understand, then I'll explain to you. Now when the bone marrow transplant, when you transplant bone marrow, transplanted bone marrow will now take up the function. So when the transplanted bone marrow starts to function, what will happen? Anybody? What will happen? The neutrophil will come back, and neutrophil will now start fighting with the enemy. Now the consolidation will start to retract. It will start to get smaller. And when the consolidation is retracting, it causes some hyperinflation surrounding it. Pneumonia छोटा हो रहा है, आसपास थोड़ा सा hyperinflation हो रहा है. This is called as the air crescent sign. Okay, I am again repeating, beta. Nobody, don't panic, beta, Arprita and everybody. I am repeating for you. So I am telling you now. So what happens is, in patients with bone marrow transplant, if you have neutropenia, you can have angioinvasive aspergillosis, which will show central consolidation surrounded by hemorrhage, which is called as CT halo sign. But when the bone marrow, transplanted bone marrow, starts to work, neutrophil starts to come back, then you have resolving aspergillosis, where the consolidation and the ground glass will retract, and there will be some hyperinflation surrounding it, which is called as air crescent sign. Okay, everybody clear? Now, just to ask you here, any other fungal infection you know that can affect the lung? There is something which became very famous. One infection that became very famous during the COVID was mucormycosis. Now, mucormycosis we have never heard of, so much before the COVID pandemic. You always remember mucormycosis seen in diabetics typically involves your nose and the sinuses, and the problem is it causes infarction of the nasal turbinates. Okay, infarction of the nasal turbinates. Okay, now try to imagine a fungal infection causing infarction of your nasal turbinate. Now if I give intravenous dye, any tissue which is alive will take up the dye because of vascularity, but if it is infarcted, it will not be enhancing. So on contrast enhanced MRI, the infarcted turbinate remains dark. It is called as dark turbinate sign. Have you heard of this before? In the last pandemic, dark turbinate sign on contrast MRI is seen in mucormycosis. It is seen in mucormycosis. Are you clear? So, and second is, it is possible, now we know it is possible to have pulmonary mucormycosis also, which earlier we were not talking about in classes in MBBS, but because of COVID it has become important that mucormycosis, if you have pulmonary mucormycosis, it leads to consolidation, with central ground glass. So it is actually reverse of what we see in aspergillosis. We see central ground glass, peripheral consolidation, like a reverse halo. And this reverse halo has, because of the fungal causing damage to the parenchyma, you will see some lines inside like this. All this is called as bird's nest appearance. Okay, this is I think there is a YouTube video by me about mucormycosis that I released during the pandemic, where we discussed the dark turbinate, etc. It is also there in your integrated rounds in your app. You can just go through, and even in the AIMS capsule there is a section on the COVID and radiology and everything. So it's a good idea to look at them, but hopefully we are beyond all this. Hopefully they should not ask all this. Hopefully this should all not happen again. So mucormycosis keywords will be diabetic, involvement of the sinus. If the sinus is involved or the nose is involved, it can go into the brain, it can go into the orbit, that is the risk. It causes infarction of the nasal turbinates, which are dark on contrast MRI. It can go into the lung, cause reverse halo bird nest-like appearance. Bird nest-like appearance. Everybody understands? Interesting? Okay. So I think, let's see. Can we continue or you want me to stop? Okay, what we can do is, okay. So I think, what we can do is we can do our ritual that we do at the end of every class. The ritual that we do at the end of every class is that we try to do the rapid fire quiz. Okay, we try to do the rapid fire quiz. Are you ready for the rapid fire? Fastest fingers, yes or no? Shikhar Agarwal and Surbhi will do it, okay, and Sakshi which will also answer. So if you are able to answer, I have today kept some tough questions for you because I thought, let me test you all with some tough questions. Let me now test you with some choices also. I want you to set the chat box on fire. I want you to let the world know कि आप सोए नहीं हैं, आप हारे नहीं हैं अभी. मैं चाहता हूं आप सबको बता सके कि आप जीतने के लिए बने हैं. Are you ready? Okay. Are you ready? So let me just see your response. Give me just 1 second. I am setting you up. Okay. Yeah. Okay. Okay. Just give me 1 second. Just give me 1 second. Okay. I see most of you are ready and setting the game on fire. Just let me see if. Okay. Now, see. Let's start now. First question. Okay. First question. Tram track calcification on the skull X-ray is seen in. Tram track calcification on the skull X-ray is seen in. Okay, anybody answer? What is your answer? Tram track calcifications. Now remember, okay, let me just get myself back. Is A, B, C, D. Cytomegalovirus, toxoplasma, craniopharyngioma, Sturge-Weber. So we already know tram track appearance on skull X-ray is seen in Sturge-Weber syndrome. That is the correct answer. And when we see in the DQB, I see the analysis in the DQB, 63% people got it right. That means if you do it before the class, it is not so easy, but after the class, you will never forget it. That is the key, and that is the ability to solve the question. Very good. I can see you are all rocking the show. Investigation of choice for acute subarachnoid hemorrhages. Investigation of choice for acute subarachnoid hemorrhages. I saw this question. Many people were asking me this question. Anybody now? Tell me. A lot of people are asking this question in the previous class also. So see, investigation of choice for acute hemorrhage in the brain is always, investigation of choice for brain hemorrhage is always a CT scan. I told you, I think if you replay my video, you will see I must have mentioned this, I think 100 times in my first class. Brain hemorrhage CT करने का, NCCT भूलने का नहीं है. Answer लिखो. 65% people have got it right. The important thing to understand is, आप सोच रहे हैं कि मुश्किल बातें करनी है उससे रैंक आएगा, जबकि आसान ही नहीं पता रहेगा. 35% people are getting it wrong. Are you able to understand what I'm trying to tell you is that what I'm teaching is enough. After my class, I keep seeing many students will write to me, sir और क्या पढ़े? मैं बोलूँगा ये तो कर ले. Do you agree कि नहीं? Sir, what else should I study? Please read what I've taught. Sir, what else? What else? And in this what else, people are selling you more and more stuff. You're buying, downloading apps. Nothing is happening. You're buying more stuff. Okay. Now next question. Anybody? Patient is suspected to have vestibular schwannoma investigation of choice for diagnosis is? Anybody? Investigation of choice for vestibular schwannoma is, I told you, beta, tell me, A, B, C, D. Now, question is, any brain tumor, I told you already, MRI is better, and if possible, do a contrast enhanced MRI. What is your answer? The answer is gadolinium enhanced MRI. Again, you can see, we discussed this in a class, you're already able to do it. But imagine when you look at the statistics on the question bank, only 56% people are getting it right. अभी आपको लग रहा है कि सर वो कोई और लोग होंगे, मैं नहीं करता गलत कभी. But it really doesn't work this way. बेसिक एक बार बनाना बहुत जरूरी है, नहीं तो हमेशा गलती होती रहेगी. Okay, so contrast enhanced MRI is the investigation of choice for all brain tumors. Which of the following is a cause of mixed cystic and solid supracellular tumor on a MRI of a 10-year-old child? Word को पढ़ लो, 10 साल, 10 year, supracellular, 10 year child, supracellular. Anybody wants to tell me? बोलो बोलो बोलो. Supracellular tumor, solid cystic in a 10-year-old child. As soon as you read the word supracellular child, कुछ और है ही नहीं भाई, craniopharyngioma. The answer is craniopharyngioma, and you can see the statistics, 63% people got it right. That means many people are doing a lot more and answering lot less in the real exams, because people are not working on the common tumors. पता नहीं क्या पढ़ रहे हैं लोग. The entire idea is focus on what is more common. Meningioma is a common tumor, craniopharyngioma is a common tumor. That is what you need to know. Okay, clear? Okay, next question. 30-year-old alcoholic admitted with fever, cough, 5 days, X-ray shown to you. What could be the etiological agent? Choice छुपा दिया मैंने. Okay, so just type the answer this time. There is a opacity with bulging fissure, alcoholic, fever, cough, sputum. What do you think? What do you think is the answer? Here the answer is going to be your Klebsiella pneumonia. This was more easy. 71% people got it right. Bulging fissure sign, upper lobe predominance, alcoholic patient. The answer is Klebsiella. Interesting? Yes. I love the energy that you bring to table. Okay. This is the toughest question of the DQB. This is there in one of my YouTube videos also. This is exact question that has been once asked in JIPMER exam also. So this is a 41-year-old man with some shortness of breath. What do you think is the problem? Now, problem in this question is it looks like a pneumothorax, but if you look at this collapsed part, the outer border is not smooth and it is not following the chest wall contour. समझो outer border ऐसा गोल नहीं है जैसा chest wall होना चाहिए था. So ये pneumothorax नहीं है. This is one of the questions from DQB I wanted to discuss in the class. This is not pneumothorax because you see that there is no obvious visceral pleural sign. Visceral pleural sign कैसा था? Convex, following the contour of the chest wall. What is this? This is a giant emphysematous bulla. In smokers, if you have a giant bulla, it is called as vanishing lung disease, vanishing lung syndrome. This is a previous JIPMER question, and it should not be mistaken for pneumothorax. बुल्लस एम्फाइसीमा में आपको चेस्ट ट्यूब नहीं डालना है, डाल दोगे तो प्रॉब्लम हो जाएगा. सो हाउ डू वी डिफरेंशिएट? ऑल्दो वी सी समथिंग विच लुक्स लाइक अ न्यूमोथोरैक्स, देयर इज सम कोलैप्स, बट दिस इज नॉट हैविंग द विसरल प्लूरा साइन. मतलब ये विसरल प्लूरा पैराइटल प्लूरा के बीच में नहीं, ये एक बहुत बड़ा बुल्ला है. दिस इज अ जायंट एम्फाइसमेटस बुल्ला. This is exact image, and that is the beauty. It is only there in your PPE kit and DQB. It is not there in any other bank because they are making students are making questions. They are not seeing what has been asked in the past and what is important. This is a X-ray showing you vanishing lung syndrome, and look at the percentage of people who got it right in the question bank. 16%. 16%. Okay. So I told you this is the toughest question on the chest radiology in the DQB. All the following show Millery shadow on chest X-ray except. I think this is the part we will discuss in the next class. So let it be. We will discuss in the next class. Loss of cardiac silhouette is seen in pathology of. Loss of cardiac silhouette. That means the silhouette sign, which is that the loss of the border, is seen in pathology of. Pathology of right middle lobe. Right middle lobe. The answer is right middle lobe. So loss of cardiac silhouette or the silhouette sign on the right side is because of middle lobe pathologies. Very good. For a small pneumothorax, X-ray is done in. For a small pneumothorax, X-ray is done in. Anybody wants to give me the answer? For a small pneumothorax, X-ray is done in inspiration, expiration. The answer is expiration. The answer is B, expiration. And you can see a good number of people got it right in the exam itself. Hampton's hump is seen in. Hampton's hump is seen in. Anybody wants to answer this question? Hampton's hump. कहाँ पे पढ़ा था? Peripheral wedge-shaped opacity on a chest X-ray seen in patients with pulmonary embolism. Hampton's hump, Westermarck sign seen in pulmonary embolism. Very good. Everybody is rocking the show now. Okay. Now what I'll try to tell you here is, and my answer today to all your problems is in this small image that I'm showing you. There's a story that was told to us all when we were children, that I think 3 or 6 blind people or people with eyes covered were shown an elephant. One person saw the tail, वो कहता है ये तो rope है, ये हाथी नहीं है, ये रस्सी है ये. Okay. One person saw the ears, he said this is a fan. One person saw the body, he said it's a wall. One person saw the legs, he कहता है ये तो पेड़ है, it is a tree. One person saw the teeth, he said it's a spear. So everybody with their own perspectives interpreted elephant in a different way. Are you able to understand this? हर आदमी elephant को अलग समझ रहा है क्योंकि उसकी आंख बंद है. So perspective is everything. Depends on how you look at the situation. I will explain to you. I will explain to you how this is relevant to your situation, and I am sure this will make you recharge for your night and tomorrow, and it should, make you think. Okay. सोचो. Listen to me everybody. Suppose exam आ रहा है. Okay. Suppose you have an upcoming exam. All of you tell me, you have an upcoming exam. How do you look at it? Is it a problem? Is it an opportunity? बताओ. Exam आ रहा है. Problem की opportunity. Perspective is everything. Some people look at exams as a problem. Hey Bhagwan, exam aa raha hai. Hey Bhagwan, exam aa raha hai. Some people look at it as an opportunity. It's a window to go to the next level. Okay. जब PMT का एग्जाम आया था तो यहां तक पहुंचे ना, उसी तरह से जब PG का एग्जाम दोगे तो अगले लेवल पहुंचोगे. It's an opportunity. But how you look at it will determine. Okay. Pandemic आया दुनिया में. So what is it? Is it a problem for you or an opportunity? Every time you have a lockdown happening, holiday happening, I saw last year some students who had not finished their syllabus till then. But in the lockdown, when they were locked down in one room, they studied a lot. And then many of them, I met them, they said, sir, mera AIMS mein 10th rank aa gaya, 15th rank aa gaya. And you will see a lot of their interviews on the YouTube channel also. So again, the question is, was it a problem, opportunity? Some people saw it as an opportunity, perspective. Exam delay ho gaya. In the last 2 years, many times exams were delayed. And I saw many students who got into central institutes. When I took their interview, they said, sir, exam was delayed, so we started studying harder. हमने और पढ़ लिया कि छुट्टी है, चलो अभी एग्जाम डिले हो गया और पढ़ते हैं. And they got into AIMS, PGI, JIPMER, they're doing their PG there. So how you look at the situation, how you look at it, your perspective is everything. Is it a problem? Is it an opportunity? अब सोचो ये क्यों इंपॉर्टेंट है. इफ यू लुक एट एग्जाम एज अ प्रॉब्लम एक नेगेटिव वर्ड है. इट्स अ नेगेटिव वर्ड. इट सेज हे भगवान प्रॉब्लम है, इट्स अ नेगेटिव थिंग एंड यू डोंट हैव एनर्जी टू फेस इट. बट इफ यू लुक एट इट एज एन अपॉर्चुनिटी, यू गेट एक्साइटेड. अपॉर्चुनिटी, लेट्स डू समथिंग अबाउट इट. ये तो करना पड़ेगा. नाउ आई मेट मेनी स्टूडेंट्स हु कम टू मी, सर मेरा एग्जाम में रैंक खराब आ गया. प्रॉब्लम की अपॉर्चुनिटी. अगेन दिस इज अ प्रॉब्लम, सर मैं तो पीछे रह गया, मैं तो कर ही नहीं पाया. And then I met another student who said, opportunity, इस बार मुझे कॉम्प्रोमाइज करना पड़ता, मैं अगली बार और पढ़ूंगा, अगली बार टॉप कॉलेज में जाऊंगा. अपॉर्चुनिटी. हाउ यू लुक एट इट इज द की. हाउ यू लुक एट थिंग्स. इज इट अ प्रॉब्लम, अपॉर्चुनिटी? प्रॉब्लम है तो काम नहीं कर पाओगे क्योंकि नेगेटिव हो जाओगे. अपॉर्चुनिटी है तो एनर्जी आएगी और काम करेंगे. अपॉर्चुनिटी से एक्साइटमेंट आता है. डू यू एग्री और नॉट? डू यू एग्री? यस. नाउ सो यू डिसाइड. नाउ आई एम गोइंग टू गिव यू अ पिक्चर टू लुक एट. Happy or sad? What do you think? What do you see? I'm doing your research test. बताओ खुश है कि उदास है? It's about how you look at it. स्टोरी को इधर से देखोगे कि इधर से देखोगे, कहानी बदल जाएगी. It's up to you. It's up to you. And your happiness depends on how you choose to look at the world. ये आदमी दीवार की तरफ देख रहा है, ये नेचर को देख के खुश हो रहा है. दोनों सेम बस में जा रहे हैं. इट्स अप टू यू. मुझे ये लगता है जो सबसे इंपॉर्टेंट बात मैं आपको आज बताना चाह रहा हूं, इफ यू चेंज द वे यू लुक एट थिंग्स, चीजें नहीं बदलेंगी. एग्जाम होना ही होगा, आपका प्रॉब्लम भी आएंगी जिंदगी के अंदर, सब कुछ होगा. बट अगर आपने नजरिया बदल दिया, यू विल विन द गेम. इफ यू चेंज योर पर्सपेक्टिव. आज लेट हो गए पढ़ने में, प्रॉब्लम के अपॉर्चुनिटी आज सर से आप 15 मिनट एक्स्ट्रा पढ़ गया, मजा आ गया. एग्री कि नहीं? इफ यू लुक एट सिचुएशन एज opportunity, you will bring more energy to the table, you will bring more excitement, more happiness, you will win big in life. So change your perspective. Today I would request you, after the class, maybe spend 15 minutes introspecting and finding out आप क्या अभी तक गलत सोच रहे थे, आपका देखने का तरीका क्या था लोग चीजों को, उसको बदलेंगे, सब कुछ ठीक हो जाएगा. आई विश यू ऑल द बेस्ट and I'm super excited right now also, and I look forward to seeing you. Please share your photographs on the Instagram. I look forward to seeing you in person. And I also wanted to tell you that after these classes, online classes will be over, I will be coming to I think first is Delhi Gautam Nagar class, and then Gujarat. I will be coming to almost every city with a face-to-face class. I have prepared a very special test, next level test for you. We will discuss everything again in a quick review fashion, revise everything for you, and I will also solve your queries regarding your strategy also. I will also try to take personal queries on your planners also. So bring your planners, bring your image book for your doubts, and be ready for the test when I come. I wish you all the best. I look forward to seeing you on 8th for the next class. God bless you. Super happy to teach you, beta. I wish you all the best.